Let's go.
Okay, good morning, everyone. My name is Rosemary Hannum, and I'm the director of the Sandra Rotman Center for Health Sector Strategy here at the school. And we are proud to host today's event, the 5th annual Research Roundtable, Data Analytics in Healthcare, in partnership with the TD Management Data and Analytics Lab. So thanks everyone for joining us. Although this event is taking place virtually, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Today's Research Roundtable is a wonderful example of two important initiatives going on at the school, one focused on the health sector and the other on data analytics. The Sandra Rotman Center is a research, education, and policy center aimed at generating insights for governments, organizations, and other key stakeholders facing complex healthcare challenges. And to do this, we bring together academics, practitioners, and policymakers to discuss current research and its application in the health sector at events like this one. And in addition, the center is also engaged in training health leaders in the healthcare sector. We offer a major in health sector management for our full-time and our morning and evening students. And we also offer our Global Executive MBA for Healthcare and the Life Sciences. And this is an MBA for working professionals, and it's customized for the healthcare and the life sciences industry. Our co-host today, the TD Management Data and Analytics Lab, focuses on helping our students and faculty gain a deeper understanding of both the power and the risks of greater reliance on data in decision-making. We are extremely pleased to have them co-host this event, as we have many exceptional speakers who can teach us how they are integrating analytics and analytic approaches to healthcare administration. So now I would like to introduce and welcome Opher Barron. He is the chair of our scientific program today. He's also a distinguished professor of operations management and the academic director of the Master of Management Analytics program here at the school. And he's also a research fellow at our center. He has an extensive CV, including numerous research papers and operations on topics such as queuing, applied probability, facility location, inventory planning, and service operations applied to healthcare and call centers. He's received countless recognitions. We're very fortunate to have him leading our operations management area and directing the Masters of Management Analytics program. So thanks everyone for joining us. And now over to you, Opher.
Hi everybody, good morning. Hopefully you can see my screen.
Yeah, looks good.
It's written, so it's good. Good to see everybody. Thanks, Rosemary, for organizing all of this event and for having the energy for pushing it this 5th year in a row. Pre-COVID, during COVID, online, mixed mode, and even now online. Hopefully next year we can do face-to-face again. So I'll go quickly about our agenda. We'll have 3 sessions. The first one of them is on technology and COVID modeling. The second one is going to be on hospital operations theory and practice. And the third one is going to be on access to care. In the first session, we're going to have first talk on waiting experience in open shop service networks, how to improve them via flow analytics and automation. We'll have a second talk on exploring the public response to COVID's technology challenges in the first years of the pandemic, addressing deployment of mRNA vaccinations, care delivery through telemedicine. And a third talk is going to be on developing pre-testing diagnostic tools for pandemic using predictive analytics, the case of COVID-19. We're then going to have 2 shorter talks on the capacitated SIR model with an application to COVID-19 and estimation the impact of asymptomatic carriers on the spread of infectious disease and interaction-based model. Those are 2 talks by our wonderful PhD students, so I'm very happy that they can join us today. In the second talk, we'll have, in the second sessions on hospital operations, we'll have the first talk on interpretable machine learning applications to triage and reassessment guidelines for ventilator rationing. The second talk is going to be on optimizing inter-hospital patient transfer decisions during a pandemic, a queuing network approach. Then we're going to have two talks by practitioners. The first one on applied artificial intelligence at Mayo Clinic, and the second one on healthcare analytics for managing and predicting weights in practice from people in Ontario Health. We'll have a short break after that, obviously, and then we're going to talk about access to care and managing weights and why it is not trivial. The first talk is going to be on treatment planning of victims with heterogeneous time-sensitive in mass casualty incidents. The second one, does delay stimulate speed up? Evidence from operating rooms. And the third one that will wrap up our event for today is how can effective patient scheduling help reduce medical procedure backlog? And then we'll basically say bye-bye to each other. Before we start, I want to share with you a little bit of kind of my thought on how do we use analytics to support decisions in general. I think we all know that the first thing that you need to do when you meet some data is to explore it and to describe the current situation. You clean the data, you try to see if you understand what's going on. So that part is descriptive analytics. The second one is going to be predictive analytics, when you are trying to predict the future. So you are going from looking at data on an existing system in the past to try to predict what would happen to this system in the future. This is done first without any considerations of changing the interventions in the system. So this is a system that I'm well familiar with. I can describe it and then I can predict what's happening with it. The trick is that what we want to be able to do is to analyze how will interventions impact the system. So there are sort of two parts to extending our analytics in this sense. One of them is to think about what would have happened in the past in this system if I would change the intervention. This can sometimes be done because, I observe two different systems. So you can think about, I'm observing several EDs, several emergency departments. In some of them, they work in this fashion. In some of them, they work in another fashion. So this comparative analytics allows us to compare different units. It also allows us to do counterfactual analysis. What would have happened if I would have acted differently? Those are really tough questions. They're still concerned with the past, though. The idea of being able to do descriptive, predictive, and comparative analytics, to me, allows us to support prescriptive analytics, which means what interventions should I implement into my system in order to improve its performance in the future. So I'm going from a system that I observed in the past, and I want to go through a system that will be better based on my recommendations for intervention, and I want to prescribe some specific actions on that. So thank you for coming here today. I'm going to stop sharing my screen, and we're going to start with our first talk. Unless anybody has any urgent issues, it is my pleasure to introduce Professor Manlu Chen from the School of Business at Renmin University in China. She's going to be talking with us about waiting experience in open shop service network, improvements via flow analytics and automation. I note that typically, as the organizer of the event, I would leave my talk to be the last one, but even Beijing is now 11 p.m. We want to allow Manlu to go to sleep at some point. So thank you, Manlu, for joining us this late, and please, the stage is yours.
Okay, thank you, Opher. So hi, everyone. Greetings from China, Beijing. So yeah, thanks. I'm in Beijing, so I'm going to be the first one to give the talk. Can you see my slides now?
Yep, looks good.
Okay. So let's get started. So today I'm going to present a work titled Waiting Experience in Open Shop Service Networks, Improvement by Flow Analytics and Automation. So this is a joint work with of a baron from University of Toronto, Avishai Mandwam and colleague beyond them from Technion, Jianfu Wang from City University of Hong Kong, and Nadia Aber from Tel Aviv Suraki Medical Center. So to start, let me introduce what is an open shop service network. In open shop service networks, customers will visit multiple stations without a specific order. For example, in these amusement parks, the customers will visit various rides and attractions in an arbitrary order. And another example is health screening clinic. As shown in this figure, this is an illustration of our collaboration clinic. So this clinic offers health examination services, which includes over 10 tests. Customers upon arrival will first register at the reception, and their first station is always the blood test.
Manlu,
Another station.
Manlu, are you trying to change your slides as you go? Because we still see the first slide, so I'm a little worried about that.
Oh, okay, let me check. You're not seeing the new ones?
No, we only see the title slide so far. So
How about now?
no, maybe try to cancel your screen share and then try to restart it. Let's hope that it would help.
Okay.
So that sometimes happens when you only share Acrobat Reader and you need to share the whole screen.
Now? No, still the first stage.
Yeah, let's say it takes a minute until we see anything. All right, yeah, no, that's much better. That's much better. Can you switch a slide for a second just to see that it works now?
Okay, does that work?
Yeah. No, no,
Okay.
it doesn't switch. All right, yeah, now it does. Good.
Okay, right? Okay.
Yeah.
Okay. So yeah. So I was just saying the customers will visit the virus testing in an arbitrary order, for example. So but there are a few precedence constraints. For example, the clinic, the cardiac stress test is always after the physician examination. And we can see that the dispatcher who is in charge of customers routing is in the center of this customer flow. So at each station, customers will have several activities. They first have this two-stage waiting. They first wait for the dispatcher's routing decisions. So basically, the dispatcher will observe the clinic's real-time situation and then assigns customers to their next stations. This manual work takes time, so the customer have to wait. And the second stage wait is after the assignment, customers will start waiting for the doctors at the stations. Then they are being called and served. So the clinic and us evaluate the system performance from two perspectives. First, from the macro perspective, we can see the total wait during the entire visit, which is the most prevalent performance measure in service systems. And second, we are also interested in the micro, the station level performance. We consider from a global point of view and a local point of view. So a global measure is a fraction of station level waits that exceeds a certain threshold. For example, a customer visited 10 stations, then how many times he or she has been waited for more than 20 minutes or 30 minutes. And global measure refers to the dynamics of the station level wait. So for example, are there 10 waits in decreasing trend or an increasing trend? So this station level performance are also very important because customers may evaluate the service based on the worst moment. And besides, we note that during this COVID-19 era, the physical distancing has turned short queues and short waits into rigid constraints. So service providers are facing the challenge of controlling this station level measures. So a few more introduction of our collaboration clinic. So the clinic implemented two technologies to improve both the operational performance and customers' waiting experience. They first has an automated customer routing system. So to speed up the routing decisions. So previously customers will have this 2-stage wait. And now thanks to the automatic routing, customers not only need to wait for servers because the routing decisions are automatically decided. And some, unexpectedly, the automatic routing only works for certain customers. Another technology is called the SMS-based customer paging system. So the system will send routing messages and calling messages when customers are routed to their next stations and when the doctors at the stations are calling the waiting customers. So our objectives are twofold. First, we want to understand the potential operational benefits and drawbacks of these technologies in such an open shop service network. And second, our goal is to explore how the clinic's new technology capabilities can improve the customer's waiting experience. Okay. So here is my outline today. I will first describe our empirical study, how the technologies affected the clinic's performance. Then I will introduce a stylized model of the clinic. We are using a 2-station open shop service network to theoretically analyze its performance. Last, we test our insights using a data-driven simulation of the clinic. So our work is related to several streams of literature. The first stream is priority and routing policies in networks. At each station, the priority policy decides which of the waiting customer will be served when the station is freed. So this is closely related to the scheduling problems of manufacturing environment. And then the routing decision decides which station should newly freed customer be routed to. And besides, our work is also related to the performance of multi-stage services, IT and healthcare operations, and buffer strategies. So here I want to mention the peak end rule. There are ample research in psychology study that customers may evaluate their service by the singular moment. So most notably the peak and the end. So therefore we are also careful with the station level performances here. So due to the time limit, I will skip the descriptive statistics. And here are our main observations of the first part. So we first find that the automatic routing redistributes the 2-stage wait. So basically it shortens the wait for routing time, but meanwhile, customers wait longer for the servers. Okay, here is the first observation. And second observation is that the SMS system significantly reduced the calling frequency and call times at each station, but the reduction had negligible impact on improving customers' total wait time. Okay, so here is how we conducted analysis. We investigate automatic routing's effect by first looking at this descriptive statistics, and then conduct some DID analysis. And by studying the SMS effect, we compare the data with and without the SMS system working. So basically, these two observations demonstrate that these two implemented technologies had negligible impact on customers' macro level total wait. So shortening the routing activity cannot reduce the total wait in the system because this routing activity is actually not the bottleneck of the entire service process. And since similarly, the call time only accounts for a small fraction of the total system time, so the practical impact of this reduction is also negligible. We next delve deeper into the dynamics of the micro level measures. Here is, so we first plot the station level wait time. So during the customer's visit from the first station to their last station for 3 types of customers. The horizontal, these horizontal lines are customers' average station level wait. So we can see that customers experienced longer delays as they progress towards to the end of their visit. So all these are in an increasing trend, right? So especially the delays during the latter half of their visit are above this average level. And such a trend also appears in figure B when we plot another micro level performance measure, which is a percentage of station level waits that are longer than 20 minutes. So therefore, we have this observation 3. And this clinic's current routing and priority policies, the micro level measures the wait for server time and the probability of excessive waits increase as the service process progresses. So, but then we ask why. So why we have observed this increasing trend? The factor that may impact this waiting time dynamics is the clinic's priority policy, because the clinic has been using the first come first serve station level priority policy to decide the service order. And this policy only considers customers' station level wait time, but ignores customers' system level information, such as customers' arrival time at the clinic, their service history, and expected future. And actually, this overlooking of system level information may contribute to the long wait at the end of the process. So therefore, we make a conjecture that priority policies that consider customers' system level information could outperform the first come first serve in these measures. Okay, this is going to be our first conjecture. So besides this station level wait times, we also investigate another related measure called unintended idleness. So what is unintended idleness? We noticed that in some cases, while customers are waiting at their already assigned visit stations, other stations they require became available. So therefore, if the customer were not already assigned, they could have started another task. But instead, both the customers and the servers at the stations are idling because the customer is already assigned to the still visit station. So in other words, the routing decisions are made too soon, especially after implementing this automatic routing. We measure the unintended idleness from the server's perspective and the customer's perspective. So we see that during the days with the automatic routing, not only the servers have higher probability experiencing this unintended idleness, but also the customer's routing decisions could be improved if we slightly postpone these routing decisions. So therefore, we draw the following observation that the immediacy of automatic routing may lead to some information loss for decision making, which reduces the system's flexibility and causes this unintended idleness for both the servers and the customers. And this observation signals an opportunity to improve these routing decisions. So what we do is we propose a buffer strategy by limiting each station's queue length not exceeding a certain threshold. Okay, and by doing this, we are in order to pull some customers in a centralized waiting pool to leave more time for collecting more information to make more effective routing decisions. So to conclude, in the first part, we find that the technologies effectively accelerated the routing and calling processes. However, since these activities are not the system's bottlenecks, this IT had negligible impact on improving the total wait. And moreover, we find that the first come first serve makes customers face a higher chance of excessive waits as they collect closer to the end of their visit. And meanwhile, the immediate routing causes unintended idleness. So we conjecture that the system level priority policies and postpone routing decisions could effectively solve these problems. Then to generate insight, we analyze a stylized two-station open shop service network. So we consider two stations, A and B. We assume station A take a longer service time than station B. So bottleneck versus non-bottleneck. Two station service times are deterministic, 1/mu, 1/kmu with k greater than 1. There are two possible routes. So AB customers who visit station A first, then station B, and BA customers who visit station B first, then station A. Okay, so we consider three performance measures. The first one is the macro level, the total wait, the overall wait time. And from the micro, the station level, we measure the customer's wait at their last station, which is the second station, and the percentage of station level long waits. Okay, and we examine two priority policies. The first one is the clinic's using policy, the station level first come first serve. And we propose to this advanced customer priority policy. So which means that the stations will give non-preemptive priority to advanced customers who finished one of the services. So in this case, station A will prioritize BA customers over AB customers. Because BA customers are finished station B, they are quicker to finish their entire service and leave the system. Then station B will prioritize AB customers over BA customers. So in the interest of time, I will just skip this theoretical result. Okay, we developed this measurement and make a comparison. So here is the numerical result. So in this figure, I plot the macro level total weight as a function of the number of AB customers from 0 to n equals to 50. Y-axis is the macro level performance, the total weight. The blue curve is the average total weight under the station level first come, first serve priority policy. And the red dashed curve is the average overall time under the ACP policy, the advanced customers priority policy. So we can see that this red dashed curve is always below or overlap with the blue curve. So which indicates that this advanced customer priority policy outperforms the first come, first serve policy from the macro perspective. Okay. And then I plot the local micro level performance measure, which is the customer's average wait time at their second station, the last station. So similarly, we can see that the ACP policy also reduces customers' wait at their last station. The third measure is a global micro level measure, is the percentage of excessive waits at stations. Here we plot two thresholds, L equals to 20 and L equals to 30. So we can see that in most cases, the dashed curve is below or overlaps the solid curve. So this also indicates that under certain circumstances, the advanced customers priority policy helps reducing the percentage of station level long waits. So to conclude, we find that by prioritizing customers with one finished service, weekly reduces customers' average macro level total weight, average micro level weight at their last station, and in some cases, the percentage of micro excessive weight. In the interest of time, I skip the impact of buffer strategy. So the last part is we then use the simulations to study the effectiveness of this ACP policies and the buffer strategy. So, we use simulations. How do we build the simulation? We built a data-driven simulation model by keeping the routing policy, servers' working times, customers' arrival times, service needs, call and service times, as in the data sample collected from the clinic. So we only change the priority policies here. We studied two generalizations of the advanced customer priority policy. The first one is the longest system time, LST priority policy, which prioritizes the customer who experienced the longest system time. And the second is the shortest expected remaining processing time, SERPT priority policy. So we can see that comparing to the station level first come, first serve, these two ACP policies, as we expected, effectively shorten the average overall wait time. Okay. We next investigate the impact on the station level performance measures. So these graphs are similar to the previous slides. The x-axis is customers visit from the first station to the last station. On the y-axis, we plot the station level wait time. So under the first come first policy, the station level waiting are in an increasing trend. But by replacing the first come first serve by this ACP policies, actually this increasing trend has been moderated. Especially this shortest expected remaining processing time significantly reduces customers' wait at last few stations. Customers spend less waiting time as their visit process to the end. Okay, similar observations holds when we plot the percentage of excessive waste. So again, the simulations confirms our results from the stylized model. This advanced customers priority policies reduce delays as customers progress towards the end of their visit. So the last part is the buffer strategy. Okay, so another conjecture we made from the data is that sometimes we could postpone these routing decisions. Okay, so customers will be routed to stations only if the station's queue lengths are below certain buffer value, while all the other customers are waiting in a centralized virtual pooled queue. So we first simulate the network under the first come, first serve. X-axis is the buffer value from 0 to 10, and Y-axis is the total wait. So we can see that, for example, set a buffer equals to 5 reduces both the average total wait and the percentage of station level long waits. So similarly, this observation holds when we replace the first come, first serve with the shortest expected remaining processing time priority policy. Okay. So to conclude, we first examine the impact of technologies, which is automatic routing and SMS, on an open shop service network's performance from both the macro, the system level, and the micro, the station level performance measures. We find that these technologies failed to have a significant overall operational impact. We then look into the data to identify the deficiencies in customer flow management. We find that the station level first come, first serve is kind of myopic that ignores customer system level information that could lead to poor system performance. And second, we noticed that the automatic routing made decisions as soon as customers finished their previous stations, and this caused unintended idleness for both the customers and users. So we then use a stylized model and data-driven simulations to show that a priority-based buffer strategy improves both the macro system level and the micro station level measurements. Okay, so any questions?
Thank you very much, Manlu. We have 1 minute for a quick question. If there's anybody who wants to share it in the chat or just unmute themselves. All right, so maybe one quick question from me. One of the main challenges in working in the context of healthcare analytics is getting good data because of a lot of privacy concern and that. Can you chat a little bit about how could you get the data for this interesting study?
Oh, yeah, actually this data set is really interesting because it's only about the scheduling policies without customers' private information, their age, their healthcare things. So I would like to thank for my co-authors for conducting this medical center for me, and yeah, just to talk with the industry partners to get the details data. Yeah.
Great. Any other quick questions to Manlu? I see you're raised up, so please.
So I have a quick question. So in your talk, you mentioned about there's like a trade-off in increasing customers' waiting time for routing and then delaying the routing decision to make the waiting time in the system more effective in the future. So I wonder, so what is the general observation that you have about, so when is the optimal time epoch to make the routing decision for these patients?
Oh, so that's why we set a buffer strategy. So we allow each station has certain queue lengths, so that there will be customers waiting at stations, and meanwhile we'll also leave some flexibility for the centralized waiting pool to make other customers waiting for better routing decisions. So right. And you can see the trade-off when the buffer value varies from 0 to 10.
I see. And then so for the two station queue, so is it always beneficial to make the routing decision after a server in one of these stations becomes available, or you sometimes will also route before that?
Yeah, because in our two station network, it also depends. So sometimes a limited buffer is better, and sometimes it's not.
Okay, yeah, thank you.
Thank you.
All right, thanks. I see we have one more question, but in the interest of time, I want to go to the next talk. Thank you very much, Rondo.
Thank you.
And our next speaker is going to be Professor Avi Seidmann. He's a professor. He's the Everett Law Distinguished Faculty Scholar Information System and Associate Research Director for Health Analytics and Digital Health at the Digital Business Institute for Questrom School of Business in Boston University. He will be joined by Professor Arriel Benis, who is a medical informatics and an artificial intelligence specialist, a senior lecturer, and the head of the technology management group, technology and management in medicine group at the Holon Institute of Technology in Israel. Avi, Arriel, thank you very much for joining us. The stage is yours.
Arriel, can you all see my slide?
Not yet, not yet.
I'm trying to do screen share. Let me try it again.
All right, this looks better.
Can you see my screen?
Yes.
Okay, good. Working now?
Yeah.
Okay. It's my delight to be presenting in the Rotman School Conference, and I would like to thank Rosemary and Opher for pulling this impressive event. I'm sending you my best wishes from Boston, Massachusetts, but my heart is also in Toronto, Canada as well. I hope next year we can meet physically. It's much better. But thank you for organizing it, and thank you for the over 80 people attending the presentation. This is an interesting type of research where we try to look at the public response to the COVID-19 challenges. And the dilemma we had was unprecedented in our lifetime medical event, and none of us had the machinery available in our profession, i.e. operations research, information system analytics. Nothing was ready at the time to address those issues. At the same time, the medical profession came with two major technologies trying to address the pandemic. One was the vaccination, which was produced in record time, the mRNA, and there were others, of course, but that seems to be the most promising, most effective. Till today, we're just 2 years past the beginning of pandemic in March 2020, and rapid expansion of telemedicine. So let me share with you some of our perspectives. This is joint research done with Professor Arriel Benis. I tried to time it so we'll have some time for Q&A, and hopefully Arriel, who is now in Tel Aviv in Israel, will be able to answer some of the questions so we make it a little bit more interactive. So let me begin. And I will start by talking about the COVID-19 pandemic and vaccination effort, and then shift into the telemedicine and how both technologies have changed and morphed. And the idea was, how do we inform decision makers as how to promote the use of these two benign technologies, but still very effective, despite a lot of hesitation, resistance, and fake media news around those particular solutions. Now, the mRNA came in first, and the public was skeptical. For HIV, for example, we still don't have vaccination, though we're almost probably 40 years since the beginning of this horrible disease spread. We got medication, which are rather effective, but still no vaccine on hand. Telemedicine is interesting because it's been around, but relatively dormant, and all of a sudden it moved front and center. And Mass General in Boston said within 3 months they have seen more than 1 million patients online, which is, of course, unexpected and unprecedented. So the technological challenge are this. We come with innovative technologies. Many of the physicians, many of the practitioners knew nothing about it. And how do we go about deploying them, and how we encourage broad-based vaccination, and how we encourage telemedicine service use? The problem is that both of these technologies were thrown at the public top-down. There was no public referendum, do you like to be vaccinated? You were told to be vaccinated. There was no referendum on telemedicine. It was the only choice available for most of our primary care, definitely, and even secondary care, at least in the first year of the pandemic. So we asked ourselves as management scientists, how can we help here? We don't have standard models to refer to. We have to kind of invent it all on the fly. In January 2021, it's just a year ago, in the United States, we peaked about 4,000 deaths per day. If you remember the freezer trucks outside the morgues in major hospital in New York City, it was a horrible event, and we kind of felt helpless. So we said, how can we help? And of course, time is of the essence. We need to move quickly and provide results in a short time. Where mortality rate is breaking anything we've seen in the last 3 or 4 generations from almost 100 years ago, since the Spanish flu pandemic, we need to move quickly. And the question was, do we go for the classical research channels that all of us who are in the referee publication business know it takes, if you are lucky, 2 years from submission to publication. In the meantime, you can calculate how many lives are lost, versus we move quickly and forgo the conventional OR, OM, IS outlets and just try to find faster ways to disseminate information, primarily using the medical profession, fast printout channels. And social media has been taking a lot of space in the pandemic. We saw a dramatic use because whenever the public is confused and people don't know what's going on, they look at social media. We need some support, some reinforcement. And the numbers have gone up dramatically, as you can see in the chart. And there are several reasons driving it. And we try to understand what's behind all that. Let me just give you one example. In November 2021, the FDA said, if you want me to release the data behind the mRNA vaccination, it's going to take 55 years. This is not fake news. That's from the FDA website. When you say 2 generations to wait for something that's been injected to billions of people, it generates a lot of suspicion. What are they hiding? So because of the FOIA, the Freedom of Information Act, they went to court, and the judge in January ordered them to release the data pronto. Still, data has not been released. And all these real facts generate a lot of suspicion in the general public. You can read more about it in other channel. I don't have time to get into it. But that generates a lot of skepticism in the general audience. Just a few days ago in Australia, in March 5, 2022, there were 2 major deaths of sport individuals, and they, of course, were claimed to being vaccinated. And there's a lot of finance behind anti-vaxxers. The more angry they are, the more people follow them, the more money they make from advertisements. So they are plain old classical incentives to twist the truth, generate anger, and drive the public. The problem is individuals believe it and refrain from vaccination, hurting everybody else. As you can see on the timeline, mRNA started taking off in the early 1990s. So it's been 30 years in the making. Human trials started about 12 years ago. And similar with telemedicine, which started in about 60, 70 years ago and slowly moving into the mainstream. So this technology has been in the background. Now they went front and center and very quickly. So our first study, we ask ourselves, what is behind the vaccination? And we did a study. We had to move very quickly. And we did it in December 2020, trying to understand when the vaccine just came out and were approved by the FDA, what is the public perception? And we wanted to move quickly. And because most of the anti-vax information was spread on social media, we said, we'll go to social media. And it was interesting for some group like Reddit tried to kick us out because they were all anti-vax, but we wanted to go in there and get their opinion. And we went to other places. We didn't pay anybody and did a major study, mostly all of it done in North America, which was the frontier at the time. We got close to 1,700 responses. And just to give you the summary of it, age, gender, having children, but best way, if you think about logic regression, look at the decision tree. It's my civic responsibility. Most of those who went for it, say, it's my responsibility to immunize myself as well as others, protecting others by me being vaccinated. Showed a lot of confidence in the pharma industry, and also were against it. Contrary to what was in the general media, large family parents were far more inclined to go for vaccination. They wanted to protect the family. And this was very interesting and fairly encouraging. Also, fear of the disease came relatively low. So it's not, I'm afraid to get sick, but rather it is my responsibility to take the vaccine and try to stop the spread and the death associated with that. I trust the pharma industry came about. And these were the message to be reinforced by public leader in order to push for the vaccination. Telemedicine is a rather interesting story because it's been around for quite a while. There's no mortal danger short run with it, of course, unless you misdiagnose a patient. And that's our second paper. But there are some fears associated with telemedicine. If you look at this one on the left, these are the patient concerns. You can read it yourself. When I go to my own physician on Mass General Brigham in Massachusetts today, and being a computer expert, I feel the same. They even send me text message. I have to take the code, type it into the machine, and only then they give me a message to call the nurse, okay? And these are the physician concerns. So both patients and physicians feel uncomfortable with this rapid technology thrown at them. Now, we wanted to find out how individuals are responding to telemedicine, and we wanted to take two systems which were rather simple, namely national healthcare coverage, rather than the US model, something similar to the Canadian. So we did the survey primarily in Israel, where there's a national healthcare coverage, and similar to Uruguay, which is Spanish speaking, and try to compare responses of the public between these two rather small countries, but one is a bit more homogeneous than the other, and try to see how this technology is being perceived over there. Again, if you do a parallel to online banking used to go to the bank or the hospital, and then they have the mini branches or the clinics and the ATMs in shopping mall, etc. So they went from the hospital or the bank major branches onto us, then became banking at home, but you had to use a browser, a desktop, and then it became mobile banking. Hospital followed suit just a few years later, and we can do a lot of diagnosis now with mobile devices. So what did you find in Israel? Participation was there, but most participants did not like additional face-to-face. They want just to do online and be done. If it's 2 steps, they would not like to use it. And they like the fact they can obtain prescriptions there, but this was only minor. Helping senior was important, but relatively a small percentage. Similarly, asking for medical advice, this was a relatively better percentage, and saving waiting time was the predominant factor there. Now, then we look at Uruguay, and then it was interesting. The primary driver for using telemedicine was somebody else in my family already used it and recommended it to me, regardless of what are the benefits I'm getting from it. Helping senior use it was not as critical. Friends usage was paramount as well. So family and friend. In other words, I would like social reinforcement that this works, you can trust it. Then I will jump into the cold water myself. And then I use it for getting medication and things of that nature. So we looked at other countries, there's a small number. The key issues, of course, the consultation is a major factor there. Social media did not play a big role, but getting specialists was something that was considered as positive one. So what did we find overall? We found that basically participants want to protect the families. They see it as a civic responsibility, and the mistrust in the professional was a major factor against vaccination. So we have to think about retention program and messages. Overlapping with vaccination is the telemedicine. technical proficiency is required, at least at some level. Major driver is reducing queuing time and reducing load on the system. And they're looking for substitution rather than a complement. If I can go for telemedicine visit and eliminate the need to go for visit in addition to that. So the technology deployment has to be supported by very clear public promotion messages sent to the public. What we learned from the telemedicine is this: Israel versus Uruguay. One, basically forcing patients to go to telemedicine is not appreciated because they're looking at 4 major parameters to make it voluntary. One, they want full substitution. If I can eliminate the visits rather than do online and then I have to drive to the clinic, I'd rather drive to the clinic. So it should be more substitute rather than a complement. Second, I want to have minimal technical proficiency as a prerequisite to do it. Thirdly, what I like about it is reduce my queuing time and the physical travel. So even with telemedicine, if it's synchronous, I have to wait for the physician to call me back and do the Zoom or the social media video contact. So the sooner I get it, the more I like it. And thirdly, I would like to see that others like it, others use it, whether it's across physician peers or residents or across my family member or individual I trust. They say, I use telemedicine, it works well. You can call your pediatrician and get advice for the high fever of your baby using telemedicine. As far as policy, some very important insights. One is telemedicine is still Wild West. Everybody thinks they can do Zoom and cure people. It doesn't work that way. There are no clear regulation, neither in Uruguay nor in Israel, even in the US. I don't know the Canadian situation. And we've done several studies, we've done empirical studies on the use of telemedicine in several chronic disease cases, including Parkinson, Huntington disease, diabetic retinopathy, chronic migraine. But other than that, I have seen very few clinical trials looking at telemedicine versus in-office visits. So the clinical value added by telemedicine, it's still unclear. The fact that patients like it, the fact that physicians like it is not cutting mustard for me. More than that, there's unestablished service level arrangement, charges, coverage, and liability. Do you pay the same? Do you pay less? Do you pay more for telemedicine? What is the reasonable service level agreement? How long should you wait for synchronous, for email answer, etc.? And the implication for physician productivity. They claim they get exhausted by all the email being sent again and again from the patient, and they feel that it encroaches on the private time. Finally, online banking is a sad story. Many banks in North America shut branches. If you want something, they're open on Monday morning and Tuesday afternoon. They cut many of the branches. So those part of the public who are not technically savvy feel they get much poor service, particularly the elderly, those with limited abilities, technologically or financially, those who don't have good Wi-Fi at home, or they live in the poor zip code areas, they feel they're not getting the quality of service they deserve by telemedicine. So it calls for a lot of policy thinking around those issues. So these are the 2 papers we published, one in Vaccine and one Journal of Clinical Medicine. You are welcome to look at that. And I left a few minutes if you have any question to my co-author, Arriel. So please, microphone to you, or Opher.
Thank you very much, Avi. If there are any questions, please raise your hand, guys. I have one quick question, Avi, with respect to really the impact of usage of technology in healthcare. On the one hand, we are used to more rapid development of technology in terms of diagnostics, possibly, and so on, where we are happy to do an X-ray and an MRI and a CT. On the other hand, here you describe a lot of fear of people of using the telemedicine as an access channel. can you compare a little bit those two different technological approaches and why there seems to be a little bit less issue with one of them compared to the other?
Yeah, it's a very good question. Maybe Arriel, you want to comment on that?
Yes, so really a very good and interesting question. We have a short time, so I will did it short. Using advanced technology like RMI, PET scans, or others are formally different from using telemedicine. With telemedicine, we are at any place, and the patients need to use infrastructures which are not depending on an health management organization, on a hospital responsibilities. And when you are using MRI or PET scan or other things like it, you are going on site. You feel more secure. You are on a physical infrastructure, and that's the main difference. With telemedicine, you are not exactly sure that you are contacting your doctor or your nurse. Anyone can disrupt with some hacking this communication, which must be secured and give to the patient to feel secured and in good hands.
Yeah. So the clinical facility gives us sort of some of confidence that is harder to get when you're sitting on your sofa at home, essentially, or I know in the subway.
Exactly.
If you have Wi-Fi. Yeah, great. Those are great points. Any other questions? Anybody?
Can I ask a question? Yeah, it just it strikes me, especially with respect to telemedicine, that really the way to assess it would be to do some kind of a randomized trial, right? Because otherwise you're always running into the bias of who is kind of willing to use it, and there are it seems just too many outside factors to control for. Like, for example, even in my experience, some doctors will meet you over Zoom, others over the phone, right? Those are very different experiences, right? And I'm sure there are lots of others. So have there been other kind of plans for any kind of randomized trials to assess the effectiveness of this?
Let me answer your question, Dimitri. You are spot on. We have done 3 randomized trials, as I mentioned, exactly the way you taught it. The point is, it takes like 3-4 years by the time you write the grant, you get the funding, you recruit the patient, you analyze the data, and so on and so forth. And what we find in Parkinson's disease, telemedicine produced superior results, way better than face-to-face, which is a surprise. We still don't understand exactly why we're analyzing it in follow-up studies. In chronic migraine, diabetic retinopathy, we call it no difference. The results are pretty much the same. So telemedicine was more convenient, but we did not produce better results, no inferior results. The problem is, we see now telemedicine used everywhere and nobody ever studied it. So we feel it's okay, but your guess is as good as mine. Sometimes physicians tell me the patient is calling them from mobile phone on the bus, okay? How good is the care? You judge for yourself.
Yeah, sometimes I feel that. And the doctor is talking to me from a mobile phone on the bus. So that's even more of a concern.
Or from Starbucks, yeah.
Yeah. All right. Arriel, Avi, thank you very much.
Thank you.
Thank you for organizing this great meeting.
No, well, you're welcome. All right, our next speaker is Professor Dimitri Kras. He's a Professor of Operations Management and Statistics and the CDC Cooper Chair in Business and Technology. He has a PhD in Operations Research from Johns Hopkins University and joined the Rotman School and not just in the previous century, but in 1989. He consults extensively in the areas of predictive analytics, optimization of marketing, communication, operational effectiveness. His research and teaching interests include the facility location model, transportation, reliability and inventory location modeling, and humanitarian logistics. He's also interested in environmental modeling, including regulation of pollution fines, marketing mix management and optimization, and predictive prescriptive analytics using big data and other tools in business decision making. He will talk on a joint work with Professor Rami Elitzer, who is an associate professor of accounting in Rotman with a PhD from NYU Stern Business School. Rami has worked in research on and teaching on predictive analytics and machine learning and in the last 8 years work on different examples of this in the usage in COVID-19, financial reporting and analysis, sports analytics, and entrepreneurship. Dimitri, please, the stage is yours.
All right. Well, thank you. It's comforting to know that I didn't join Rotman 2 centuries ago. It sometimes feels like it. Okay, so
we can see your slide, and now it's in presentation mode, so everything works well here.
Perfect. Good. Well, let's hope it keeps working. So I'll jump right into it. Opher already introduced myself and Rami, and Yael Zimlichman is our co-author from Israel, and the one who is actual, the relevant medical doctor, unlike the rest of us. Okay, so briefly, I'll talk about the setting and the research objectives, and talk about optimal test submission policies, a variety of them, starting with the simplest, and then introducing repeated testing and pool testing, and talk about the machine learning models that we used and the website, and discuss the case study. So the objective is quite simple. Right? How to best use limited testing resources. And to me, this is not really about COVID, but COVID is a great and most recent case studies. As we all know, I think we're all experts now in testing. I lost count how many times I've been tested, but I'm expert enough to know when it's not doing right. And PCR testing is considered gold standard, and medical authorities consider this crucial in identifying infected individuals. On the other hand, testing resources are limited, and we could all see it in Ontario, where we reside, where it went through from very limited testing at some stage to the attempt to test anyone who wanted to be tested, to quickly rolling it back and saying, no, only selected groups will be tested, eligible for testing. And it's, I kind of lost count where we are now, right? But clearly the resources are limited, and these limitations, by the way, occur in several places, and the bottlenecks are shifting. At some stages, it was a lack of swabs, believe it or not. At other stages, it was the testing equipment, the lack of nursing personnel who were qualified to do it. And so it seems like as soon as one hole is plugged, another one appears. And there are other inherent limitations to testing as well. So PCR test, even though it's considered gold standard, it's also kind of well known that it's not perfect. And apparently it's not so bad as far as false positives. It's considered, that the false positives are at most 1%, even though even there's some debate about cycle counts and so on, where when you use high cycle counts, you're more likely to produce false positives. We will use figure of 1% throughout the paper, but the estimates are that at least in the field, as opposed to in lab, there's 20% or more false negatives. And this is due to a variety of factors, ranging from how the testing is done. Maybe the nurse is not doing it appropriately, not catching the specimen not being transported properly, or just the physical nature of the disease where the virus is present in the nose at some stages and then not in others in various quantities. And the other limitation is it's not immediate. Again, all of us are experts now, and it's not infrequent, right? That last time I was tested, I believe it was at the airport. I think the results came 3 days later, and my wife's results never came. So, it's not something that you can do interactively, right? And so our approach and our idea was, well, when somebody shows up for testing, we actually have a lot of information available about them. And this information, I'll talk about it later, but this information includes symptoms, right, that somebody might or might not have. Also patient characteristics such as age, gender, and so on, and reason for test, right? Are you being tested because it's a work requirement, because you're not feeling well, because you just came back from travel? So all of this information is available and easily collectible before somebody gets tested. And so the question is how to use this information for optimal deployment of limited resources. And by this deployment, I mean things like admission. Should this person be admitted to testing, right? And this occurs in what we in operations call online format, meaning it's not like you have all patients presenting at the same time, and you can select from them who should and should not be tested. Patients come more one at a time, and in each case, you have to make a decision. Do I admit this person for testing or not? You could also administer repeated tests, right? If you know that 24% or more are false negatives, that means that possibly it makes sense to retest some patients. Should you do that? Pool testing is extremely popular right now. And the idea there is, instead of testing individual patients, I take samples from a whole bunch of them, mix those samples up, test the whole sample, and only if the sample comes back positive do I then go back and test individuals whose samples were pulled. Now, I'll point out that this pool testing will overcome some limitations, but not others. So if your bottleneck is nurses to administer the test or swabs, pool testing will not help. But if your bottleneck is processing equipment, then it will. So that was the genesis of the study. And, you know, it's traditional to mention prior work or do a short literature review, and I won't do either. I'll just mention the prior work. So there's 2 parts to this research. One is using machine learning for predicting test outcomes. So this is kind of the background. Before we can do, as Opher described, prescriptive analytics, decide who should and should not be admitted, we need some prediction of how likely this person is to test positive if we do test them. And so some of that work has been done, surprisingly, mostly on small data sets. And just reading the articles, a lot of times data is not in good shape because people have to hand code notes to identify symptoms that were, you know, the patient was presenting with. Which boggles my mind because this data should be easy to organize. There's been a few exceptions. We are aware of one study in Israel which did use a large data set, but there they had to pay a lot of money apparently to the provider for this data. So for some reason, for whatever reason, this data, right? Of course, anytime someone gets tested, presumably some record keeping is kept of the person, the age, gender, and so on. For some reason, the data is not being made available. So we were lucky enough to have access to a large data set. And on the test design, there is a large literature on pool testing. But we are more interested in connecting this machine learning models, the prediction, to the policy, and we are not aware of much literature on that at all. So that's my view of the literature. So some key assumptions that we are making. First of all, testing resources are constrained. We have a population presenting for testing, which is much larger or significantly larger than T, which is how many people we can test. Now, this is also our objective, and this is important, is to discover true positives, right? So if you think about it in a Bayesian way, the outcomes of testing could be a true positive, a false positive, true negative, or false negative, and to us, it makes sense that what you're really after is uncovering true positives, right? In other words, those people that are infected that you identified as infected, so you can isolate them, you can quarantine them, and so on. And we can talk about test efficiency, number of true positives you uncovered by administering these t-tests. Finally, another assumption is that data on previous tests is available, right? So we are not starting from scratch. We have some idea about prevalence of the disease. So this is an ongoing manner, and we have some previous data to build our models on. So we need pre-test information and test outcomes. As already mentioned, we assume patients show up one at a time. And upon observing the available information, here's what we can do, right? We can either accept or reject the patient for testing. So that's the admission policy. That's one option. We can decide to test a new patient or retest an already tested patient. So if somebody comes in and we think they're very likely to be infected and the test comes back negative, we may want to retest them. This is quite common. We can also decide, so this is sort of an alternative to one where instead of rejecting a patient and saying, sorry, we don't have test resources available for you today, you can decide to direct everybody to either individual testing or pool testing. So the idea of pool testing is I test everybody, but some people I test individually and others as part of the pool. So we call it mixed testing. And let me kind of, I'll probably go a little bit faster, but this is our baseline, right? So this is sort of what we call random admission. So you have population that shows up for testing, and you have disease prevalence Q that you don't know ahead of time, but you can estimate. So you, some of them are tested, some of them are not tested. You have this outcomes, false negative, true positive, true negative, or false positive. Now, the positives come back with a positive result, P, that you get to observe. The negatives, come back with a negative result. So this is what you observe. And because you have data and you know beta 1 minus beta alpha and 1 minus alpha, because you've done previous studies on the test, then you can estimate the estimated prevalence, right? Just work this out, a trivial calculation. But for some reason, by the way, people don't do that. They report P as the prevalence, which kind of boggles my mind. And you can also compute test efficiency, which is Q times 1 minus B. That's 1 minus beta. So this is for a random admissions process. When you don't, when you admit everyone, you don't exercise any admission control at all. And so just as an example, right? So this is based on our case study. If I assume 1% false positive rate and 20% false negative rate, and 48% are testing positive, then the estimated prevalence is actually close to 60%. So shouldn't be confused with this P. And the test efficiency is about 48%. So you could say, in this limited test resources environment, about 50% of your test capacity is wasted which is amazing given that the prevalence is 60%, right? So you're not deploying your resources very well, even in this high prevalence environment. In Ontario, and most times we had prevalence of something like 3%. So there the wastage is much larger. So what is the screened admissions process? What does it look like, and what are we thinking of here? So again, on this side, I have no screen admission, right? Just for reference. And then, you know, what do I actually do? So I observe the patient information, and I apply machine learning models. Of course, you know, so I have two groups of patients basically, and I don't know which group a patient belongs to. So group one is positive if tested. If I decide to test them, they'll come back as positive. And group two is negative if tested, right? So if I test them, they'll come back as negative. Now this positive is drawn from true positives and false positives, and negatives are drawn from false negatives and true negatives. But again, I don't know where a particular patient belongs. And what I can do is I can observe patient information, gender, age, reason for testing, symptoms that they're presenting with, apply a machine learning model, and try to predict the test outcome. So the machine learning model will tell me this patient will test positive, or this patient will test negative. And that gives me these two important quantities, the sensitivity of my machine learning model and specificity of my machine learning model. And once I have those, I can work out, you know, what will happen if I admit a patient for testing. So all of these quantities are easy to work out, and these ones I reject, right? So you know, those ones I think that shouldn't be tested at all in this regimen. And of course, here some of them I reject wrongly. I should have tested them because they were positive, and these ones I rejected correctly. So all of this is not hard to work out, and I can work out the test efficiency under this regime. And the important thing, again, what's driving this whole thing, and I think that probably what's the interesting part, at least to me, of this research, is the linkage between machine learning and decision control. And the linkage comes here, this sensitivity and specificity of my machine learning model, right? And you might ask, where do I get those parameters from? And the answer is, well, this is exactly what the common evaluation for machine learning does. This ROC curve that, you know, we are all used to seeing, it plots sensitivity versus 1 minus specificity for your algorithm of choice. So here I present a whole bunch of algorithms, and basically every point on this plot refers to a particular policy. You could say, if you admit this percentage of patients, then you can have this sensitivity and this specificity, right? So I get to choose any point on this plot, and I can then use it, feed it into my decision algorithm, and see how what test efficiency will result. So the linkage is easy and direct, and that leads to the following policies, right? So the policy is basically, again, it's pretty trivial. Admit if predicted probability of positive test is higher than a certain percentage. So I look at my predicted probabilities from my task. I look at the percentiles of what percentage I have resources to test, and I look up the probability of that. So that's my threshold. And any patient for whom, so a patient shows up, I run them through my prediction model. If their predicted probability is higher than this threshold, I admit them. If it's below that threshold, I don't admit them. And I have two results. We have two results here. So first of all, this screen-based testing improves on random admission as long as your model is basically better than random. So the sum of sensitivity and specificity is bigger or equal to 1. So if your model does anything at all, predicts better than random, then you're better off doing this. And secondly, if this result holds and alpha plus beta is less than or equal to 1, so that says that your test, your PCR test, is also better than random, right? So I need two things. I have two sources of uncertainty here. One is how well the test is doing that I'm using, and secondly, how well my model is doing. So if both of those are better than random, then the policy I described above is optimal. In this class of policies, where I get to accept or reject the patient.
Dimitri, a quick question on that. So in fact, what we've seen through different times of COVID is that testing was recommended based on kind of tracing, right? Please test yourself if you've been in neighboring, you've been 6 feet or low for more than 15 minutes. So we didn't have a machine learning algorithm that did this triage for us, but basically policymakers said, hey, please only go to test if you satisfy this criteria.
Right. So indeed things changed. And I'm comparing to a baseline, which is a theoretical baseline, which is a random admission, but that's not quite how the testing was done, right? And I don't need to make that assumption. So this improvement I'm showing is over random baseline. Now this, by the way, what you're mentioning, of course, is exactly what we are using in the machine learning algorithms. Right, which one of the items there is reason for testing, right? So there were different groups because some groups were told to show up because you were identified through tracing, others because you want to visit your relative in a long-term care home, and so you have to be tested. Somebody just came off the plane, they have to be tested. Somebody else is coming in because they're not feeling well. So you always have a large mixture of groups, right? So it's not, and other times it was completely random. Anyone who feels like they want to be tested can be tested. So what I want
one more comment.
Right?
So thanks, Dimitri. You have about 1 more minute, so hopefully you're wrapping up soon. By the way.
Yeah. Okay. Sorry. So I will rush for the results, but this shows that the efficiency gains. Of course, it depends on what percentage of the population you want to admit. If you admit 100%, you have no gains. But with reasonable admission policies, you can realize large gains. I'll rush through some of the other results quickly. So should you retest? Well, with random admissions, the answer is no. It's never optimal to retest. With this machine learning-based admission, possibly. So there are conditions where indeed you want to retest rather than admit a new patient. Basically, intuitively, if the model says somebody is likely infected and the test comes back negative, then you want to retest. And pool testing, there's a lot of information here. I'll just say that you can indeed extend the results to pool testing, and you have some kind of a combined policy where individuals that the model thinks are very likely to test positive should be tested individually, and everyone else should be tested with pool testing. And you get, and that way nobody is rejected, everybody is tested one way or another, but and you have a combined policy. Now, I did want to talk about this. So all of this is based on machine learning models, and so we developed this automated pipeline for machine learning, and it was actually I'll go here, right? So where with the help of NITI from TD MDL, we have a nice automated software that ingests the data. So the data is easily structured, so it ingests it, breaks it up into training, validation, and so on. Automatically, applies a whole bunch of models. So I listed the ones that we use, and then evaluates them on out of sample validation and selects the best one. and uploads a scoring algorithm to a website. And the implementation is on this website where, patient comes in, you tell me how many people you can test today. You can tell me how many people you expect to show up. So that gives me an idea of what percentage should be admitted. And then you enter the information for a given patient, and a scoring algorithm from, in this case, random forest classifier that was the best model is applied, and it recommends, yes, you should test this particular person or not. So this is how we implemented it. We applied it to a case study, and I'll just say, I guess, two things to finish up. I realize I'm a little bit over time. One is, in your machine learning algorithm, in addition to what you know about the patient, it's really important to include time series terms, such as the typical prevalence. What is the positivity rate over the last 7 days? How many tests did you administer over the last 7 days? Things like that. And you can see it here. So the red line is the test results. So what percentage of people are testing positive over time, and you can see how unstable it is. The green line is the model, in this case, a simple decision tree that uses prevalence as one of the predictors, and you can see it follows the red line very closely. And the blue line is the model that doesn't use this time series terms. And you can see you are under predicting at the times when really the prevalence is very high. So that's important. And the second is, this models, even though we only had 5 symptoms, so I thought the data was pretty poor. All we had for the age was whether you're over 60 or under 60. We had gender, we had the reason for being tested, and we had 5 symptoms. That was all. You're still getting AUC of about 0.91, which gives you very, very nice differentiation between sensitivity and positivity. And with that, many times, if the model says somebody is likely to test positive, you can take it to the bank. I mean, you don't even have to wait for PCR results. So as a doctor, you can start treatment immediately rather than waiting a day or 3 days until PCR is available. I think that's
very much, Dimitri.
Yeah, sorry about going over time, but
there is a question by Avi. Do you want to take?
Maybe no. I think maybe you can chat during the break. I'm sorry, Avi, but we have one more talk, and we are running 5 minutes late, which is kind of as much as I'm allowing myself. So maybe on the break we can catch up with that. Thanks. Very interesting. Our next talks, as I said, are 2 short talks by Chaoyu Zhang, who is a PhD candidate at the Rotman School. Her research interest is in data-driven work on supply chain management. And then Yaniv Ravid, who is another PhD student in our group, would present a project dealing with asymptomatic carriers in the epidemic. Chaoyu, please, the stage is yours.
Thank you. Hi, everyone. I'm very happy to be here to share with you a recent work I have done. And the topic of my presentation is Capacitated SIR model with an application to COVID-19. And this is a joint work with Professor Min Chen and Professor Ming, who are from University of Toronto. So, as we all know, the coronavirus pandemic has affected our lives, our economy, and nearly every corner of the globe. It has sickened more than 460 million people worldwide, and more than 6 million people have died so far. So researchers have studied various mathematical models to try to understand the spread of the virus and its transmission pattern. The classical SIR model is arguably the most popular one. So SIR model is a kind of compartment model describing the dynamics of an infectious disease. The model divides the whole population into 3 compartments, and each compartment is expected to have the same characteristics. Here, beta is the parameter controlling how much the disease can be transmitted through exposure, and it is determined by the chance of contact and the probability of disease transmission. And gamma is the rate at which infectious individuals will recover. We can think of it as the reciprocal of the average time it takes to recover. Thus, we can write the ordinary differential equations as follows. So besides using SIR model to model the disease transmission pattern, there is another issue, which is testing. So testing is a critical step to contain the outbreak. But we can see from this figure that at early stage, most states in the US remain far from the minimum level of testing needed to reduce the spread of the virus. Even nowadays, testing is still important. Across the US, now the attention has shifted from testing to vaccination, but there are many benefits of testing. First of all, through testing, we can diagnose sick people, and then we can slow the spread of the virus, and also we can assess our progress. And there are rich literature in the COVID-related area. For the time being, I'm going to introduce some of these papers. So the first research direction is to use the transition modeling to study the COVID-19. For example, in the paper by Professor Birch and his co-authors in 2020, we proposed a spatial SIR model to provide an optimal way for social planners to control the spread of the disease while reducing the economic costs. And the second research direction is to include the testing capacity in the traditional component analysis. For example, in the paper by Professor Rotman and his co-authors in 2020, we proposed a compartment model with a different set of 13 states to study the effects of testing capacity and social distancing measures on the evolution of the pandemic. So all their models are very comprehensive and captures the major characteristics of COVID-19, which include the existence of asymptomatic cases, isolation, and hospitalization. But our goal is to derive a parsimonious model, and we only want to check the testing phase of the cases. And we also want to model the different propensities people with symptoms and people without symptoms may get tested. So, okay, now let's move on to our model setup. And in our model, we designed a component model with 4 states. Here, S means susceptible population, they are healthy, and people in state I means they are infected and they have shown symptoms. And people in state A are those people who are infected but they show no symptoms. And people who are confirmed of having COVID-19 belong to state C. Besides, people who have been self-healed also belong to state C. Here in our model, we assume people will not be infected again once they have been recovered. First, we look at the transition from state S to state I and from state S to state A. The parameter rho means that among all the infected people, a fraction of rho people have shown symptoms. So the larger rho is, the more people will show symptoms. And beta I and beta A are the infection rate for people in state I and people in state A respectively. Next, we look at the transition from state I to state C and from state A to state C. So infected people will transit to state C either by testing, which is the first part, or by self-healing. So the gamma is the testing accuracy divided by the testing turnaround time, and K is the testing capacity, and delta is the degree of testing people without symptoms. And lambda I is the self-healing rate for people in state I, and lambda A is the self-healing rate for people in state A. And here is our system dynamics. So our model is a discrete time model based on the number of people in each 4 states at time t. We can use these equations to compute the number of people in each 4 states at time t plus 1. And we can use this equation to figure it out and explicitly write the number of people in each state at any stages. Now let's look at the practical implications of our model. So our model can be used to decide the allocation of limited testing resources. First, our model can study how to allocate the limited testing resources among different populations. Also, our model can study how to allocate testing resources across time. When we study how to allocate across time, we first study a 2-period model, and then we extend it for a multi-period model. First, we look at how our model can be decided on the allocation of testing resources among different populations. Here, the parameter delta represents the degree of testing people without symptoms. So you can see from this figure, all the people in state I will go to test, and the fraction delta of people in state A will get tested. And we have the following proposition, saying that there exists a threshold H, which is a number less than 1, such that when the infection rate of people in state I is smaller than the H times the infection rate of people in state A, we should allocate more testing resources to people without symptoms, which is we should increase the parameter delta. Otherwise, if the infection rate of people in state I is much higher, then we should allocate more testing resources to people with symptoms. So we should decrease the parameter delta. And next, we look at how our model can be decided on allocation of testing resources across time. First, we study a two-tiers model, and we show that there exists a threshold larger than 1, such that if both of the infection rate of people in state I and people in state A is larger than this threshold, then we should allocate all the testing resources to the second tier. Otherwise, if both of the infection rate of people in state I and people in state A is smaller than this threshold, we should allocate all the testing resources to the first tier. Next, we extend the result onto a multi-tiers model. To solve this, we propose a dynamic programming method, and the whole time horizon is cloud-based. So we want to study how to allocate the limited testing resources across cloud-based. And the optimal value function is the V star, which is a function of people in state S, I, A on data, and the testing capacity on data. And we write the Bellman equation as follows. And here's the constraint of the Bellman equation. So we solve this, and we can get the result on how to allocate the testing resources on cloud-based. Besides study the allocation of testing resources, we also study how to rank the different testing methods. We propose a testing index, which is the testing capacity times the testing accuracy divided by the testing turnaround time. So we compare the rapid test with molecular tests on Ontario, Canada, and we show that the testing index of rapid tests is much higher than the molecular test, which indicates that at current time, we should increase the number of rapid tests. Also, we have a bunch of structural results related to our model parameters. And for the time being, I'm going to skip this part. Next, we look at the empirical study of our work. So we use the COVID-19 data from the COVID tracking project, and we extract the daily number of completed viral tests and cumulative confirmed cases from this data set. And we use the sliding window method to identify. And we use the sliding window method to identify the changes of model parameters. And we extract the number of tests on data to represent the KP in our model. And we use the number of confirmed cases on data to represent the CP minus lambda I times IT minus lambda A times AT in our model. And here's our result. So this is the estimated parameters for Florida state in the US. And we set the window size as 45 days. And we can see that both the infection rate of people in state I and people in state A is the highest on phase 2, which is still open. And we also show that for the parameter gamma, delta, eta, how this parameter will change across time. We can see that gamma remains stable, which makes sense because it's the testing accuracy divided by the testing turnaround time. And delta and eta is very symmetric. So let me now briefly summarize my work. In my study, we propose a capacitated SIR model, and we provide the policy implications like how to allocate the limited testing resources and how to choose the best type of testing methods. And we use the sliding window method in our empirical studies to test how the parameter will change across time. So I think that's all. Thank you very much, and I'm very happy to take any questions.
Thank you very much, Cho-Yu. I want to go to the next talk first, so Yaniv will have enough time as well. And if anybody has any questions for Cho-Yu, let's please hold them to the break. Thank you very much.
Thank you.
Yaniv, you're next.
Perfect. Can you guys see my slides?
Yes, they look excellent.
Thank you. All right, perfect. So hi, everyone. I am Yaniv. I'm a PhD student here at Rotman, and today I'll be presenting a joint work with Professor Avi Seidmann. Starting with some motivation, we've recently looked into how epidemiological models affect healthcare responses to viral outbreaks, and we found that they are very lacking in one particular area. Many of these models can only project and predict the number of infectious individuals by describing subgroups of a population with a single number, as seen by the figure on this slide here. The blue, red, and green plots are best fit solutions to a model that by itself at any point in time cannot tell us anything else about the population other than what its size is. And in response to the recent pandemic, governments and organizations have worked around these weaknesses of the classic epidemiological models by developing the necessary digital tools. For example, Taiwan developed its own mobile application to keep track of the pandemic, so did Germany. And for the Toronto locals in the audience, you may be familiar with UCheck, which helps U of T mitigate the pandemic's impact on the university. And bringing this back to my previous slide, clearly there's a gap between what epidemiological models can tell us is going to happen and what they tell us we should do. And this is where we think that digital healthcare and analytics can combine to produce powerful tools to help combat viral outbreaks, where each member of the population is individually characterized as a potentially infectious vector and not just a single number of some aggregate. The classical models we use as a foundation are similar to SCIR, which we went over in the previous presentation. So for the sake of time, I'll kind of just reiterate their weakness, which we're trying to resolve, and that is that these models differentiate between subgroups of the population, but not between individuals. And the implication that this has on combating epidemics is clear. If I randomly select any individual from a population, how do I know which subgroup they belong to? If I wanted to know anything about the population other than what the probable size of each subgroup is going to be in the future, these models cannot help me. And to answer this, we propose a modification to the SCIR that, again, similarly to what we just saw, splits the infectious group into symptomatics and asymptomatics, and the differential equations that model the dynamic maintain their form with a few key differences. The most important, which is this new parameter, which kind of attenuates the percentage of the population that becomes symptomatic or asymptomatic once they're exposed. In order to identify specific individuals as potential vectors, who can expose others to the disease, we make a few assumptions. The three most important ones is that time increases in discrete intervals. Exposure can only occur when individuals are in some sort of proximity. And when we say proximity, we mean they share an infection cell, which we'll look at later. What that means, we also assume that contact is traceable and known. And lastly, exposure can occur with some probability, which attenuates how infectious grow in the population. We also go on to formalize the difference between symptomatics and asymptomatics. We apply the modification that we propose to SCIR that controls the probability of individuals becoming either symptomatic or asymptomatic. And we note that we assume that all symptomatic cases are known. Now we can start thinking about how a model like this can help us identify specific individuals, specifically those asymptomatic ones. We mentioned that the assumptions include that all interactions are tracked, and we use these interaction histories to solve the problem. What we specifically do is create an interaction matrix, which counts the amount of interactions any pair of individuals in the populations have had. For example, let's assume at some initial period, we have the following configuration, right? So this is our space. Our population is 4 individuals spread across 4 infection cells who fit this grid form. And for the sake of the illustration, we don't know what subgroup of the population they belong to, right? We're assuming that we don't know who's susceptible, asymptomatic, incubating, or otherwise. And if this is the initial configuration of the system, the interaction matrix will look something like this. So because individuals 1 and 2 have only interacted with each other, entries Y12 and Y21 are non-zero. Let's say we go into one more step in the future and allow individuals to move around the world. Some new interactions occur. We see that individuals 1 and 2, for example, interact one more time, but now they also interact with individual 3, while individual 4 still does not interact with anybody. So we update our interaction matrix accordingly. But now assume that individuals 2 and 3 begin to show symptoms. Recall, one of our assumptions is that all symptomatic cases are known. As soon as someone shows symptoms, we know who they are. So we can go to our matrix Y and look at the rows who are corresponding to all known symptomatic cases. If we add these rows up, we're going to get a 4-dimensional vector in this example, which we refer to as V. And that represents the amount of interactions that all known symptomatic cases have had with the rest of the population. And high entry in this vector would indicate that an individual might be potentially asymptomatic. And in this case, the entry for individual 1 is pretty high, while the interaction entry for individual 0 is pretty low. We can use this vector, for example, to define some sort of binary classifier. If we impose a threshold of 2, individual 1 could potentially be classified as a likely asymptomatic, while individual 4 will be classified as a potential non-asymptomatic. So we test this sort of classification model on a simulation of 5,000 individuals, and we see some somewhat interesting results. So since the infectious population grows and shrinks over time, we found that the best possible results occur when we classify before the peak of infectious cases. And in this particular example, a 70% true positive rate is associated with a 10% false positive rate, which means that we can correctly identify 70% of all asymptomatic individuals and the population, while only falsely flagging 10% of non-asymptomatics. And finally, we run an experiment to not only just try to see how accurately we can classify asymptomatics, but what happens when we actually use the classifier during the outbreak, right? So we impose some realistic restrictions on our classifier, and we say that only 10% of those individuals that are flagged as asymptomatic are actually removed from the system. And the results are quite interesting. So even though we approximately only remove 90%, or we keep 90% of asymptomatics in the system, the peak in the infections is more than half. So in purple, the dashed line shows what the number of asymptomatics would have been without our classification model. And even by removing only 10% of asymptomatics in the simulation, the solid line shows that the peak of the wave is cut to less than a third. And in red, we see a similar result for the symptomatics individuals. And even though these results are still theoretical, to the best of our knowledge, no other analytical tool has been developed to kind of address this problem that asymptomatic carriers present to public healthcare management. And when it comes to this issue, it's clear that the intersection of healthcare and analytics lead to some powerful tools, such as our classification methodology, which is actually patent pending in the US. And on that note, I want to thank everybody for listening. This project is still a work in progress, so we look forward to hearing your feedback and questions. Thank you.
Thank you, Yaniv. Any questions to one of the last 2 speakers? So I'll take a minute from our break. We're supposed to go into a 10 minutes break now, but Xiao, you and Yaniv, you both use the SIR model, and this model has been studied extensively in the literature. Why do you think that COVID kind of caused it to be less appropriate than previously? What are the specifics of COVID that made it a less accurate representation of reality in comparing to other diseases? So Xiao, if you can address this first, please. Thanks.
Yeah, because in our study, the main goal is to track the testing phase of the whole process. So we choose the SIR model, but we change the state R to the confirmed of having COVID-19. So I think this is a difference with the traditional SIR model. So we just use this framework and we change a little bit.
Yeah, Yaniv?
Sure. Yeah. I think the quickest, simplest answer is that it's too simple to describe a very, very complex problem. It's obviously easy to interpret its results, right? When COVID started, New York Times, any publication would just have that page where they show the projected numbers. It's easy to digest. But when it comes to making decisions, when it comes to affecting policies in healthcare, there's not much that it can do other than just predict.
Yeah. So I think, I mean, stepping back into analytics in healthcare, there is the benefit of being able to communicate kind of the main aspects and the main issues using this basic model. But if you want to tailor it to specific applications, the devil is in the details, as you can imagine. So thank you very much for all the speakers in the first session. We have 8 more minutes of break. So let's take a couple of minutes to stretch ourselves. Maybe we grab a cup of water or coffee, and see you here at 10 for the next exciting session. Thank you for joining, everybody. Rosemary, I don't know if you have like elevator music to put in the background for now. I didn't think about it until now.
Good idea. And nothing on hand. Let me see what I can find.
Yeah. And anybody, if you have some thoughts you want to exchange in the chat, please feel free to do that.
Opher, I need soon to leave for class, so I must apologize. So I will need to leave the conference.
Yeah, thanks for joining so far. Interesting work. I think it's important to have this triage, especially when we see how busy those testing facilities are. So yeah.
Thank you. It was very interesting to work on that, and when we start to work on that, of course, the idea was not, it's not going to be considered much at the Rotman, but we thought it could actually help practitioners.
Yeah, so hopefully we have a couple of practitioners that join the event, and if we can create some further collaboration with them, that would be great. All right. Have a good class.
Thank you.
Barry.
Bye, Remy.
Thank you, Dimitri. Talk to you soon. Thanks.
All right, everybody. So got a couple of minutes to stretch ourselves a little bit, do a couple of emails on the side, but I hope you are ready for our next session. So we'll have four more talks now until 11:40, and then we'll take another break. Then I hope I'm not missing the schedule here by too much. Yeah, and our first speaker is Julien Grand-Clement. He's an assistant professor in the Information Systems and Operations Management Department at HEC Paris. He completed his PhD from Iowa Department at Columbia in 2021, and his research interests lie broadly at the intersection of data-driven decision-making for healthcare and optimization algorithms. Julien, please, the stage is yours.
Thanks, Opher, for the nice introduction, and thanks for the invitation. Can you confirm that you can see the slide changing?
Yeah, looks great. Yeah.
Okay, thank you. So the topic of the talk is on interpretable method in machine learning and the application to triage scarce healthcare resources. So it's a joint work with my collaborators at Columbia University and with the critical care team at Montefiore hospitals. So in the last 2 years, we have all seen a lot of examples where there were some challenges in managing the access to life-saving health resources and cases where the demand was far exceeding supply. So here I'm thinking of beds in the intensive care unit and critical appliances such as ventilators. There's also been some example where even classical therapies such as dialysis or oxygens have run in short supply. And in response to this, there's been some official triage guidelines. So here the goal is to support frontline clinicians in their decision and alleviate the burden from them, and to promote trust from the public, transparency in terms of what is being done in the hospitals, as well as consistency of the response across the territory. So the goal in this project, and what I will present today, is threefold. First, we want to evaluate the existing guidelines in terms of the number of lives saved. So most of these guidelines, their goal is to maximize the number of patients that survive typically the pandemic or the natural disaster, and we want to obtain an estimation of how well they perform. Second, we'll see how to somewhat improve upon those guidelines, and there will be an emphasis on interpretable method that will use machine learning here. And there will be particular interest also on the ethics and fairness criteria in the model. In particular, in the end, those triage decisions, somewhat they withhold life-saving appliances from some patients, and they direct them to patients that are most likely to benefit the most from them. So it's important to know what specific subgroup of the population are involved in those decisions. So again, the collaboration from the clinical side is with Montefiore hospitals, and we will obtain the data from them. I will focus first on describing the New York State guidelines. So in short, the key question is as follows. If you are in a situation of shortages, who should have the priority to ventilators access? So typically in the United States, you have a majority of states that have some form or another of official allocation guidelines. And in New York State, it's this document. So it's a 270 pages document that was designed after Hurricane Sandy hit New York State real hard and created these dire situations in intensive care units. So the objective is to maximize the number of lives saved. And there are, it is focusing on ventilator allocation. There are three epochs of decision. First decision is at T equals 0 hours of intubation. So it's the moment when you decide whether you should intubate the patient or not. So the first decision is at triage. should we withhold the ventilator? So if we estimate that the patient may not survive even with ventilator therapy, maybe we will rather keep the ventilator to a patient that have higher survival chance. Then you have two reassessment periods, one at 48 hours, so after 2 days of intubation, and one at 120 hours, so 5 days of intubation. And again, we can see if the patient is improving in terms of his health condition and decide or not to withdraw the ventilators. Now, the decisions are based on some specific information. The goal is to try to keep it simple. In particular, we have these decisions based on what we call the SOFA score. SOFA stands for sepsis-related organ failure assessment. Think about it as an integer between 0 and 18, and it's a risk score. So the lower the score, the higher the chances of survival. And if you have a very high SOFA, the chances of mortality are pretty high. So the New York State guidelines create priority classes for intubation. So for instance, at Triage, it's represented here. Typically, you have exclusion classes. For instance, the blue category here is when you have some certain specific exclusion criteria, or if the SOFA is higher than 11. So they have chosen this threshold of 11, and they assume that patients with a SOFA higher than 11 are not likely enough to survive, and therefore they will not obtain the ventilators. Then you have intermediate priority if you have a SOFA higher than 8 but lower than 11. So very severe condition, but still some chance of survival. And then the highest priority are essentially SOFA between 1 and 7. So somehow you have a stratification among patients. After 48 hours and 120 hours, you have different criteria. Now somehow you have slightly more information. The idea is that you can see if the patient condition is improving or not. And therefore you can see if the SOFA score is decreasing, and that can create more, highest priority even with higher SOFA. It's just that the patient is still is at least recovering after 2 days or 5 days. Okay, so this is the official New York State. It can be a little more accurate. First, is this saving more life than the first come, first serve policy? So first come, first serve is simply allocate ventilators to the first patient that needs it on the fly until you hit capacity. So you're not prioritizing. In which case, should we revise guidelines if that is not the case? Second, can we find an interpretable policy within the framework of the New York State guidelines, but that improves upon it? So here we'll use data from COVID-19 and some analytic method to compute interpretable policies within this framework. And third question related to fairness, should you include information on demographics or comorbidities within those decisions? Or is it enough to just use the SOFA score? Okay, so that's what we will address in this talk. But first, I want to discuss a little bit, why does it sound like a good idea to use data and analytics? A priori, it's a medical question, right? It's a clinical question. Should you give a ventilator to that patient? So let's talk about this first. So in the last few years, there's been some achievements and some hype in the media about this artificial intelligence and healthcare, let's call it what it is. With, for instance, IBM Watson and a lot of papers and investments for medical decisions and artificial intelligence. So here you can see that the rate of the investment is essentially growing exponentially, but also in terms of healthcare data, it's growing really fast. And the estimations are that half of the healthcare data that exists now have been created in the last 2 years, so broadly defined. So it's really going very fast. But at the same time, most of what is currently actually deployed, so not academic papers, what is actually used of artificial intelligence in healthcare is mostly operational. So this is a study of the projected market shares and shows that essentially AI can help with, for instance, billing and fraud detection and scheduling. But in terms of changing the patient treatment, it's far from being the majority of what is currently being used. And I would like to argue that one of the many reasons for this, but a critical one, is the issue of interpretability. So in particular, if we think of these guidelines, they are supposed to support clinicians during high stress situation, Therefore, they need to be explainable really quick so that they can be operationalized easily and that they can be discussed with the medical staff. So in contrast with that, most of the artificial intelligence method and algorithm and decision models are what you call black box. What is the image here? Essentially, you have some input for the model, maybe vital signs or lab values, or maybe a radiography. And then you have this large opaque decision model. Think about it as maybe a neural net or a regression. And then it outputs a recommendation for a treatment, maybe use therapies or identify some malignancies on the radiography. But it's very hard to explain what is the decision model and to justify its decision to a large audience. So that's the issue of interpretability, and somehow it hinders the applicability of those artificial intelligence methods. So there are many models of interpretable decision. Here I'll focus on a very simple one because we can represent it graphically. It's decision trees. So if you recall this table for the New York State guidelines at Triage, we had some cutoff on the SOFA, and it's an easy, perhaps a simpler representation is on the right, figure B, where we simply represent the New York State guidelines as a decision tree. So you have a sequence of if then else condition where you simply inspect the SOFA score of the patient, and then you have priority classes at the bottom of the tree. So for instance, is the SOFA higher than 11? If not, is the SOFA higher than 8? And so on and so forth. So it's a simple representation. You can do it also for the New York State guidelines after 48 hours and after 120 hours. Now you have more information, so you can see if the SOFA is decreasing. And then, of course, you can also incorporate more information like age and BMI and comorbidities in all generality. So these models are very popular in machine learning, but somehow they are mostly for static problems. So what do I mean by this? You have some information on the patient, and then you use it to create some kind of classification. But in healthcare, the decision you take at a given period in time will have an impact on the evolution of the patient afterward. Typically, allocating the ventilator or not is very important decisions. And therefore, you do not simply have to take a decision at each time step. You have to take into account the fact that the decision you take at time 1 will influence where your patient will transition at time 2, and so on and so forth until the end. And therefore, it's not enough to simply obtain a decision tree at each of the time period. What you want is to obtain decision trees that are somewhat aligned with your goals of maximizing the survival chance of the patients. It's not enough to simply obtain a decision tree independently. You have to take into account the time series aspect of the decisions. So without entering too much into the details for the essentially the algorithmic method, it's possible to use a form of backward induction where we start from a good tree at the end and then backpropagate the information about the tree in the future to trees in the past, so that we can obtain a good sequence of decision trees. So let's go back to COVID-19. So our goal now is to obtain the sequence of decision trees. There already exists one, the New York State guidelines. Can we use our method to obtain perhaps a better one? So essentially modify the cutoff of the SOFA higher than 9, higher than 11, that kind of things, and obtain overall a higher chance of survival of the patients based on the data. So in our setting, the decisions are quite simple. They are to intubate or extubate, right? So withhold and withdraw the ventilators, and they have to be taken at the first time of intubation, so what I call 0 hour, then 48 hours after, so 2 days of intubation, and then 5 days of intubation. The idea is that you have more information if the patient is recovering or not. So we use a retrospective data set that corresponds to COVID-19 patients from the first wave of COVID. This is why it's not so many patients, between March and June 2020. We have first what I call static information, in the sense that they don't change within the trajectory of the patient in the hospitals, like age, BMI, and comorbidities. And we also have what I call sequential information. It's just the SOFA score updated every 2 hours. So the SOFA score is pretty simple to compute, and the nurses can compute it and update it very easily. And we observed that there was a maximum number of ventilators used at the same time of 253. So the hospital did not reach capacity. But now the question is, if they had 200 ventilators, they would have been short of 53 ventilators. So what would have been the number of deaths associated with this potential shortage situation? So in particular, what is the typical patient trajectory in the hospitals? Well, maybe at the first time of intubation, the patient had a SOFA of 10. Okay, so it's intermediate priority classes. And then at 48 hours, the SOFA score is decreasing by 1 unit. So patient is recovering, slowly but recovering. So patient is in a high priority class, and then patient is recovering after 5 days, and then eventually the patient is extubated when the patient has almost fully recovered. So that's a typical trajectories, and we have a certain number of them. So we use a simulation model to generate these patient trajectories in the hospital, and we want to compare what if the number of lives saved by New York State versus first come, first serve, so just allocating ventilators on the fly without any prioritization, versus what I call trip policy, which is use our machine learning model to tune these cutoff for the SOFA score. And the input is a certain number of ventilators available, typically n equal to 100. So I'm short of ventilators, I needed more. What would have been the number of deaths? So I will go through our conclusion of the experiment now. We first observed the following fact, which is that the New York State guidelines, so which was designed in 2015, only save as many lives as first come, first serve. So what does it mean? It means that it's not doing better. It's performing roughly on par with a method that is not prioritizing the access to ventilators, so not trying to compute chances of survival and then prioritizing patients. And if you think about it, that makes sense. So these guidelines, they have been designed a while back. So even though they have been designed by experts and clinicians and policymakers, they are broadly defined. So in the document, it's defined for typically a nor'easter or a flu pandemic or a severe flooding after a tropical storm. And therefore, they are not adjusted to the specific of COVID-19. And this is why, even though they make sense, right, they create prioritization of the patient, they are not improving upon almost random allocation. Second, we see that you can improve the number of additional deaths, so lower it, by significant proportion, about 25%, by adjusting this cutoff. So somehow, if we respect this framework of decision at 0 hour, decision after 2 days, decision after 5 days, and you tune these thresholds using our algorithm and the data on COVID-19, we can drastically lower the number of additional deaths. So we see it's important to use the data, respecting the official framework, but essentially adjusting it to the COVID-19. Here it also raises the question of when should you tune your decision, in the sense that we've been able to do that because we have information on COVID-19, right? And this is the reason why the New York State guideline is not working so well, is because it does not have the information of COVID-19. So you should wait a little bit to reveal some information about the disease and then adjust it. And obviously you can't just adjust it every 2 weeks and propose a new solution. You have to do it once and for good, or at least once per year or something in that flavor. Other insights from the simulation are that if we focus on this ethic and fairness criteria, it may not improve the number of lives saved to include more information. So typically, if we include the information on demographics and comorbidities, we may not have a higher number of patients that survive. So here you can see it in different ways. First, that SOFA score is enough itself, for the simple score between 0 and 18. So it's enough to take your decision on how to withdraw or withhold the ventilators. It has been shown in some studies that it correlates positively with mortality from COVID-19. At the same time, you can argue that the demographics and comorbidities themselves are reflected in SOFA in the first place. So even though SOFA is simple, if you have a high BMI and cancer, it will lead to higher SOFA in the first place. So it's twofold here. Finally, we see that in our model, we find that it's easier to identify patients with higher chance of survival after a certain amount of time of intubation. So typically, after 5 days of intubation, it's way easier to create this prioritization and to identify who are the patients that are most likely to benefit from intubation. In the end, it's quite logic because you've been able to observe typically if the SOFA score is decreasing or not after 5 days of intubation. So somehow this suggests that maybe if you want to be more efficient in terms of number of lives saved, you should have more proactive extubation rather than withholding into triage decisions. Of course, from the clinical staff standpoint, it can be a harder decision to extubate the patient than not giving the ventilators in the first place. So this has to be balanced with how you manage the clinical staff. So I can conclude briefly here. We essentially have a first methodological contribution with this model that we identify for interpretable sequential decisions. Think about them as sequences of decision trees. And then you need some analytics/machine learning model to optimize and find the good sequence of decision trees that take into account the future of the decisions and not just find a good greedy decision at every time step. From a practical standpoint, I think what we're trying to do is simply to respect the framework that has been developed in the past by the official guidelines, but within this framework, so this decision timelines and basing the decision on the SOFA score, what we're trying to do is essentially tune the decisions using some data we've had. In terms of future work, there's a lot of potential projects here. So evaluating with different cohorts or patients with COVID of the different waves. It's also possible that changing the timing of reassessment help a lot. So here we would break this official guidelines framework, but at the same time, maybe 5 days of intubation is too short to decide if the patient is already recovering from COVID-19 or not. So typically, stay in the ICU can be pretty long with COVID. So maybe it's too early after 5 days to take this decision. It's also interesting to design these guidelines that take into account ICU capacity. So the current framework is to activate these triage guidelines when you are at capacity. It could be interesting to activate them maybe when you are at 90% of the capacity so that you have a smoother transition. So with this, I thank you for your time, and I'm happy to take questions. I think there has been a comment in the chat, but I did not see.
Yeah, no, that was just me kind of trying to tell you what the time is going or to get soon. Thank you very much, Julian.
So I see one question by Chen Ding. So will it help by incorporating system state information, QLF, available resources into the triage decision process? So here there's a few answers. So intuitively, from an operations management person, I think more information always helps. That's at least the intuition. At the same time, for instance, queue length, I'm not sure that the practitioners will have this information in the first place live, in the sense that they don't necessarily know how many people are waiting for ventilators in the backlog, or even waiting for ICU beds, or available resources. How many ventilators are available? How many ICU beds are available? These are information that are not so easy to have. Typically, for ventilators, some have been repurposed. Some are from operations that are cancelled. Older ventilators being repurposed also. So it's not clear that you can have this information in the first place. Vahid, I think I see your hand is raised.
Yeah, so I was wondering if you've thought about equity-related performance. So is it possible that an algorithm that minimizes mortality, sort of penalizing certain demographics or populations? Or just wanted your thoughts on this.
Yes, so we have this information in the data. Typically, we have race and ethnicity. So we can do those computations, but they were not statistically meaningful. So I will not draw a conclusion here. Now, it's fairly involved because typically comorbidities, specific subgroup of the population will have more prevalence of typically high BMI diabetes. So there's a lot of correlation here. But yeah, we've tried to compare what is the proportion of white, Latinos, African American that are excluded from ventilator treatments, and we did not get anything statistically meaningful. So I will not comment on that. I see another hand.
There's another hand, but I do want to continue with our agenda. Okay. So thank you very much, Julia.
Thank you.
Feel free to address the other question in the chat, but for now I will introduce our next speaker, Vahid Sarhanyan. He is an assistant professor of mechanical industrial engineering and the director of Center of Healthcare Engineering at the University of Toronto. And I'm proud to say that he has his PhD from the Rotman School of Management. So it's always great seeing our guys doing well in life. Vahid, thank you very much for joining us. The stage is yours.
Thanks for the introduction. Can you see my slides?
Yeah, looks good. You can even try to change one, just that will make sure that it works well.
Changes.
Yeah, and I don't know if you can make them a little bit larger. It looks like you're not in presentation mode. So
yeah, I can go to full screen.
Yeah, I think full screen would
better.
Be okay. Yeah, it's a little bit better.
All right, so this presenting joint work with my colleague Timothy Chen from also the Mechanical Industrial Engineering Department at U of T. Francis Bogakar, who was a master's student working with Tim and I, and now is a senior analyst in Ontario Health. Eric Helston, who is a health policy expert who was and is at Ontario Health, and Fahad Razak and Amol Verma, who are internal medicine physicians at St. Michael's Hospital and also clinical researchers. So as the title suggests, our work is also related to the COVID-19 pandemic. In terms of motivation, so one of the main challenges that health systems across the world had to deal with during the pandemic was this geographical mismatch between demand for hospitalization and where the hospital capacity and resources were. So as very nicely summarized in this New York Times article headline, you had cases where one hospital or some hospitals were overwhelmed, had very high occupancy levels, while other hospitals had plenty of capacity. And there are lots of evidence in terms of the association, or in some cases causal relationship between high occupancy levels and worsened health outcomes, which also leads to certain issue with respect to inequity in access to care. As for example, as you see in this headline from New York Times again on the right, if you were in a poor neighborhood in New York City, your hospitals are all overwhelmed, so you're more likely to not have access to sort of hospitals with nicely staffed physicians and nurses and adequate resources. But if you were in a nice neighborhood in Manhattan, you had access to private medical centers which had plenty of resources. So one solution that sort of came up during the pandemic in multiple countries, including here in Canada, was to use inter-hospital patient transfers. The idea is to, if you have imbalances between different hospitals, you basically put a patient in an ambulance or multiple patients and transfer them to other hospitals which have capacity. This was used at high quantity, especially in Ontario. So during the first 3 waves of the pandemic, more than 3,000 patients were transferred here in Ontario with, in April 2001 alone, more than 1,000 patients were transferred here in Ontario. Who made these decisions? In Ontario, these decisions were made by the Incident Management System, or IMS, who are essentially a group of coordinating health managers that oversaw the transfers of non-ICU patients. Our work was initiated in collaboration with Ontario Health that provided quantitative supports to the GTA, or Greater Toronto Area's IMS, which oversaw around 64% of transfer activity in the province. And the way they would essentially work is that the team would come together on a weekly or sometimes even daily basis. They would review sort of the current occupancies of the hospitals and projections of the occupancy over the next few days, and they would come up with a plan in terms of transfers. They would basically provide guidelines to the hospitals in terms of transfer this many patients to this hospital, and then the hospitals would implement them at their own discretion. So our work aimed to develop sort of systematic approach to guide these transfer decisions by developing a mathematical framework. And we also wanted to sort of use data from Ontario to look into the potential benefits of using transfers. Transfers are costly, not only in terms of the actual transfer cost, but also in terms of the amount of time that physicians and health providers need to spend transferring information, preparing the patients for transfer. And they could also be risky. They could be associated with sort of poorer outcomes, which we don't know much about. So it is important to understand what is the benefit of these transfers in terms of balancing occupancy and other performance measures. And the approach that we sort of took was to sort of model the patient flow within and between hospitals using queuing network model, and then formulate the problem of optimizing inter-facility decisions as a stochastic control problem for this network. We then developed a solution method and validated the model and tested it using data from 21 hospitals in the GT. So here's a sort of high-level overview of our queuing model for a single hospital. It's a two-stage tandem queue with blocking. So patients could arrive directly to the ward or the ICU according to non-stationary Poisson processes. They would sort of go to the ward. They may be discharged after a random amount of time. That could also be time dependent. With some probability, they need also ICU care, so they move on to the ICU. They may die in the ICU or be discharged. All of these sort of parameters could be time dependent as well. And we sort of, because of the empirical study suggesting that COVID and non-COVID patients could have significantly different characteristics in terms of length of stay, mortality rates, and so on, sort of accounted for two patient classes, COVID and non-COVID. We assumed infinite capacity in the wards, but ICUs had finite capacity. And if a patient needs to go to the ICU, but the ICU is at capacity, they would essentially be blocked and stay in the ward. And this is again, sort of motivated by actual practice, especially in Ontario. Many patients who needed sort of ICU care had to stay in the ward and be intubated or receive sort of ICU care in the wards. So what is now our sort of optimization or control problem? This was the model for a single hospital. Now we consider a network of edge hospitals modeled by these tandem queuing networks. And then we looked at sort of a discrete time control problem over a finite horizon of length, let's say T. The decision epochs were at the end of each day. So essentially at the end of each day, we would review the state of the system, which is the number of patients in the ICU and wards of all of the hospitals and their types, COVID and non-COVID. After we've realized all the new arrivals or new patients for that day, then we would make a decision in terms of how many patients of each type should be transferred from hospital I to J for all sort of I-J pairs in the network. Right, so a little bit more formally, or an admissible policy is a mapping from the current states to the number of new patients that need to be transferred from hospital I to J. And our objective is to find the best policy that minimizes the total expected cost over this finite horizon. What is the total cost? It is comprised of three components. The first component is an over occupancy cost. So we essentially penalize or incur cost as we have patients per units of time above occupancy thresholds. So for example, these occupancy thresholds could be 95% or 100% for ICU and wards. And per patient per unit of time that the hospital spends above these occupancy thresholds, we would incur a certain cost. We may want to penalize sort of ICU occupancy over the ward occupancy, so we have sort of different weights or coefficients for the two components. We also accounted for transfer costs, which is essentially to capture all the costs associated with patient transfers. The costs have a fixed component, setup cost, and also a distance-dependent variable cost. So if a hospital is farther, then we would penalize that more. If a hospital is sort of within the same network of hospitals, then the setup cost is lower compared to a hospital outside of that network. The last component is COVID load iniquity cost, which is to sort of penalize for number of patients per unit of time above the hospital's fair COVID share, where we define the hospital's fair COVID share to be essentially proportional to their bed capacity. So if your hospital has 20% or maybe 2% of the total bed capacity in the network, then your fair COVID share is also 2% of all the COVID patients in the network. If you have more COVID patients than that, then you would incur certain costs. This was actually sort of the main objective that the IMS group sort of had in mind when prescribing their decisions. They did care about sort of over occupancies, but actually the main objective that they had was to balance the distribution of COVID patients across the hospitals, because they were in situations where some hospitals had very large number of COVID patients where others didn't really have that many. So these are the three components, and a weighted sum of these are sort of the expected total cost of or control problem. And again, we are trying to find policies that minimize this expected total. So very briefly about the solution model. So this is a very large, essentially an MTB, but it has a very large state space and exact methods would be intractable. So we looked at a fluid approximation of a single hospital model, which is justified by a functional strong law of large numbers and essentially provides accurate approximations when the system is large. In this case, we are dealing with hospitals with a large number of beds, so that in most cases was not a bad approximation. We then heuristically sort of proposed an associated fluid control problem for the entire network. And that, as I'll briefly talk about it, that is a problem that we can solve for large instances of the problem. And then we translated the solution from the fluid problem to the original stochastic system using the model predictive or rolling horizon approach. So very briefly about the fluid control problem. So the state is essentially the number of COVID and non-COVID patients and the wards and ICUs. And here we think of control or decision variables as being the fraction of class K ward and ICU fluids arriving at a hospital that needs to be transferred to other hospitals. So our objective is essentially the counterpart or a corresponding cost function to what I just described, subject to some constraints that essentially make sure that all patients either stay in their own hospitals or are transferred somewhere else, given some initial conditions and a bunch of sort of constraints describing the sort of dynamics of the fluid model. Here we can also add additional constraints. For example, we may want to limit the number of daily transfers or the transfers over the horizon, so we can add sort of whatever constraints we want here. And this essentially gives us a non-convex after discretization optimization problem, but one that we can still solve efficiently using the MIP formulation using an off-the-shelf software. So once we solve this problem, then we can translate it to the stochastic system and sort of evaluate its performance using simulation experiment. So in our case study, we used considered 21 hospitals in the GTA area. And we evaluated the performance of our policies with respect to sort of two main performance metrics that are also in our cost function. The number of patient days per hospital spent over the 95% occupancy in wards and ICUs, and the number of patient days per hospital over a fair share of COVID patients. We looked at 3 periods over the pandemic during 2021. So these correspond to different sort of times during the 3 waves of the pandemic in Toronto. The first one is right after the first really bad peak in January 2021. The second one is sort of a little bit later after we are recovering from the pandemic. And the third one is right before things get really bad for the third peak. They used a variety of data sources to calibrate or models. They had access to patient level data from the Gemini data set, which our collaborators manage. At that time, this only had patient level data from 7 hospitals. So we had to sort of make some sort of interpolation or estimate or parameters and extend it to other hospitals. We also had daily occupancy, admission, and discharge data from Ministry of Health and critical care info that allowed us to sort of estimate some of the parameters for different hospitals separately. And we also had access to these transfer directives that the IMS transferred. So these are the actual guidelines that were supposed to be implemented. So we validated our model using simulation experiments. We developed 95% confidence bands for the occupancies and the wards and ICU using simulation. And then we looked at the historical occupancies. And for the majority of cases, 83% for the wards and 93% for ICUs, these historical trajectories were sort of included in the confidence bands, providing some sort of evidence for the validity of our models. Then we looked at the performance of the policies, and in particular in comparison with no transfer policies, to sort of get a sense of the value of patient transfers. In general, we observed significant gains based on our policies in terms of these performance measures that I introduced, even when the daily transfer patients were limited to 5. So we had somewhere between 13 to 21% reduction in the VARD and 11 to 23% reduction in the ICU over occupancies, and somewhere between 0.4 to 9.2% reduction in COVID loads and included. So these are expected reductions, but also we saw benefits over the entire distribution of the performance measures. So here, for example, we are plotting the CDF of the total patient days over COVID fair share under 3 policies. The blue one is the optimized transfers with the COVID balancing objective included. The green one is the no transfer policy. As we see, the CDF is significantly shifted to the left. And the orange sort of CDF corresponds to the optimized transfers, but without including the COVID balancing or COVID fair share piece of the objective. As you see, that one doesn't achieve the same benefits as the blue CDF. But interestingly, if we sort of look at the same metrics for over occupancy or same plots for the over occupancy metrics, we'll see that the COVID balancing comes with little sort of impact on the over occupancy reduction. So if I look at the same CDFs for over occupancy in ICU and ward, the CDF for the orange and blue curves are very close to one another. But we still get significant benefits comparing to the no transfer or the green CDF. So in a nutshell, we can get benefits in terms of COVID balancing without having much impact on the over occupancy reductions or benefits. And intuitively, this is because if your hospital is overwhelmed with COVID patients, so you can basically choose them for transfers, and that allows you to basically gain benefits for both objectives. We also looked at the benefits as a function of the maximum number of daily transfers that we allow. Again, these transfers are not free, they're costly, they occupy a lot of time, ambulance resources, and so on. So we looked at what is the benefit of adding or allowing for more transfers. And as you may expect, we saw diminishing returns in terms of allowing for more transfers. So in most cases, with just allowing for maximum 5 daily transfers per day, we actually achieved the majority of the benefits. And this was sort of practically appealing because for collaborators, because it was good to know that with a small number of transfers, you can essentially achieve the majority of the benefits. We also looked at sort of the optimal trajectories to gain insights into where these benefits come from. One interesting observation was that proactive work transfers were actually could actually provide lots of benefits in terms of ICU load balancing. So here, for example, on the left, we're looking at the normalized occupancies under no transfers. So if you don't do any transfers, as you see here, hospital and QD, things could get really bad. We will have above the capacity occupancy levels. On the right, we see the same trajectories under optimized transfers. And as you see, these benefits in the ICU are actually achieved by sort of doing transfers in wards. So before things get really bad in the ICU, we would transfer a large number of patients from the ward in anticipation that they will eventually, some of them might need ICU care to avoid getting sort of to these bad occupancy levels in the ICU. So I don't know how I'm doing on time. Do I have?
You have 5 more minutes. We can dedicate them to questions, or if you need another minute or two for your summary. Yeah,
so let me summarize and then we can turn to questions. So we essentially propose a queue network approach to guide patient transfer decisions. Similar to what Avi described, we also had to sort of work with collaborators with sort of 1 to 2 week deadlines to sort of get some results done. So this was that kind of research where we had to sort of push to get results really soon. We evaluated the performance of our proposed framework in a case study. Sort of main results are then we can actually get significant reduction in ICU and ward occupancy levels by doing these interfacility patient transfers. And then nicely, much of the benefits are actually realized with doing a small number of transfers. So we may not need that many transfers to sort of balance the occupancy levels across hospitals. And also we saw that by including this COVID fair share cost function in the objective, we could actually get significant benefits in terms of COVID load balancing without sort of sacrificing the benefits for over occupancy reductions. So we are currently working on a bunch of extensions on this work. Some of them are with respect to model and data extensions. This was a stylized model, although we had some evidence for its validity. We hope to sort of make it more realistic and use more data for calibration. We think that that would sort of improve the performance of our model and its closeness to reality. We're trying to now sort of look at the structure of optimal transfer policy by looking at a much more stylized model to sort of gain insights into how, and here we basically looked at just computational method for the transfer policies, but we would like to gain insights into what is the optimal structure maybe for simpler systems. In particular, we want to see if maybe the majority of these benefits can be realized by looking at a sparse network. So here we assume that each hospital can transfer to any other hospital, but is it possible to maybe get the majority of these benefits by pairing hospitals or having a small sort of networks of hospitals that collaborate together? Again, sort of coordination is very costly, and so that would be nice to have sort of a small number of hospitals working together. And then finally, we have data from the actual transfers, including patient level data. So we hope to look at, sort of empirically look at the cost of transfers in terms of impact on the outcomes for patients. If it is the case that if you transfer a patient, then the mortality rate is going to increase, then maybe we shouldn't do that many transfers. But if there's essentially no impact on the outcomes, then maybe transfers can be used more widely. All right, so thanks very much. I'll stop here. Happy to answer questions.
Thank you very much, Vahid. I see a question from Julia, so please.
Yes, thanks, Vahid. I'm wondering about the limit of scale here. So I can see this at a city level. I can see this at a region level. Can you do it like at the scale of whole Canada, like maybe part of North America? Like, what's the limitation in terms of like number of hospital distances?
Yeah, so that's a good point. I mean, actually in Ontario, patients were transferred to very far places. So if the demand is there and then all the hospitals are occupied, then that's something that might be possible. Again, in Ontario, there are these centralized groups that can coordinate such transfers. In other countries, it might be more complicated to send the patient to somewhere far away. In Europe, you might notice that actually European countries were transferring to each other. So it is possible to do that at a larger scale, but that could, comes with higher costs and more coordination and information costs.
Thank you.
Yeah, I think the thought of the optimal coalition of hospitals to kind of manage this process adequately is not a simple question, but certainly an interesting one. I see another question in the chat. If you can take a look at it, Vahid.
do you expect that a small number of transfers have the same level of effect across hospitals with varying bed counts? So I'm not sure if I understand the question fully. So we did have, in our case study, we did have sort of hospitals with varying bed counts. So we had very small hospitals and also large sort of teaching hospitals. And so these observations, at least empirically, that we had in terms of sort of the benefits of a small number of transfers do include hospitals with different sizes. But let me know if that I misunderstood your question.
Thank you very much, Wahid, for the talk.
Thank you.
And I want to introduce our next speakers from Mayo Clinic. We have a tool, Darnorker, sorry, a tool for massacring your last name. He's a principal health system engineer at the Mayo Clinic in Rochester, Minnesota. He has a master's in industrial engineering from Rutgers University and has worked on a range of projects in analytics, AI, and optimization in healthcare. Adam Resnick is a health system engineer in the strategy department at Mayo Clinic. He's from Centennial, Colorado, and has a master's degree in management analytics from the Rotman School of Management. Hey. He has previous experience as a software engineer, data analyst, and a machine learning researcher working in public health. Thank you very much, guys, for joining us. The stage is yours.
Wow, well, wonderful. Thank you for the introduction, Opher, and we're so glad to be here today. We are doing a presentation today on applied artificial intelligence at Mayo Clinic. And Atul and I wanted to first open with talking about the opportunity space at Mayo Clinic, just to have a little bit of context for the two case studies that we're going to present. So we wanted to present two case studies, each that kind of raise an interesting research question. So overall, a little bit about Mayo Clinic for those who aren't familiar. Mayo Clinic is a large integrated health system with large hub sites in 3 states. So Rochester, Minnesota, Phoenix, Arizona, and Jacksonville, Florida, as well as a health system that spreads across 3 states, really 2 major states in the Midwest. So Mayo Clinic has a major, huge facility in Rochester, Minnesota, which has about, you can see here, these numbers are a little outdated, but about 40,000 employees. And then we have a health system that spreads across the Midwest with smaller hospitals that are still larger, and then very small rural hospitals that serve rural communities, as well as destination patients that come to Rochester, Minnesota for like subspecialty care, both in an inpatient and an outpatient setting. So just a little bit of the context for some of these projects. So Mayo Clinic has a 2030 strategy to cure, connect, and transform healthcare. So there's been a renewed focus on AI and digital innovation within Mayo Clinic. We inked a 10-year partnership with Google, which you'll kind of see scattered into our presentation, which has kind of put a big renewed focus on building new algorithms, both for clinical care and for administrative functions. So that's a little bit of the background of why a lot of this work is being done and a lot of the excitement that's being generated around our institution. So I'm going to hand it over to Atul to talk a little bit about our patient journey map. Oh, Atul, I don't think we can hear you.
We still can hear you, Atul. I don't know if your mic is off. Because you don't seem to be muted at our end.
Okay, can you hear me better?
Yes, now it's great. Thanks.
Okay, perfect. Well, what you see here is the typical Mayo patient journey. Most of the patients come to Mayo from national or international site through a referral from an external provider, and they go to maybe an internal medicine visit, and then they have few lab, radiology, see a specialist, and sometimes they may have a surgery or inpatient encounter as well. So what we want to show on the top hand side are some of the work that AI is impacting along the patient's journey. There are a lot of work which are going on with the referral summarization, because we see with some of the complex specialty, more than 500 pages of document, and we want to give the due respect to the patients to understand their history before deciding, can we help this patient or not? And a lot of our work in AI in the specialists are transforming the internal medicine or primary care by helping to screen and diagnose the patient earlier, maybe in the asymptomatic phase, and also helping those specialty to triage them to the right specialty. And I think for the lab and radiology, there has been a lot of work which is going on, radiology being with the transformation of deep learning and computer vision. But I want to talk more about we are doing a lot of work in generating longitudinal patient summary, treatment planning, and remote monitoring in specialist area. But also a lot of work is going in making intelligent devices for surgery, processing the data which is captured during the surgery, a lot of video-based data so that we can use it in future AI development and developing surgical intelligence. Adam, if you want to go to the next slide. In Mayo Clinic, we always feel that AI ideas can come at different stages. An idea can come internally as an idea or proof of concept from a physician, but also it could come externally from a startup company as an MVP product or vended product. So any capability we develop, we want to cater to an idea at any stage of maturity. And in the next slide, we have what we call as 10 pillars of clinical AI. So the reason they are important is that whenever we treat our patients with any of those AI product or use any of the AI product in their treatment journey, we want to make sure that they are robustly developed and they help patients, not harm patients. So we these are the 10 pillars. I'm not going to go through all of them, but I want to highlight a few of the important ones. Is during the discovery side, we want to make sure that the data is representative. And if the data is not representative, we can partner with our academic partner or industry partner to make a robust data set before it can be translated, or before an algorithm can be developed or translated. We also want to make sure that we have a robust translation programs which meets the regulatory standard. And in the end, we want to make sure if we develop the model, it's sustainable both financially as well as technically, and it provides the best patient and provider experience. And I'll hand off to Adam for the next few slides.
I'm going to walk through a brief case study that is similar actually to Vahid's case study on transfer that we just listened to. So this is a case study that's coming from our clinical area. So it's focused really on patient care. It was a discovery phase algorithm. So this was a very early stage prototype that our emergency department wanted to build. And they wanted to kind of showcase and learn more about Google AutoML as well, which kind of featured in this project because that was a tool that they're interested in exploring more for developing both administrative and maybe potentially clinical algorithms in the future. So about Mayo Clinic in the Midwest, as we discussed, there's hub hospitals. So there's a few hub hospitals in the Midwest that can manage complex patients. And then there's spoke hospitals across the region that are those rural, less resourced sites. And the goal is to manage patients locally as much as possible. So transfers are to be avoided if at all possible in order to reduce healthcare utilization of those expensive transfers by ambulance or by helicopter. So the objective of this project was to predict which patients would require hospital transfer to enable an earlier preventative intervention. So something like telemedicine, which is currently in practice at Mayo Clinic. So you get if you see a patient's probably going to need to be transferred, get a second opinion from a telemedicine ED doctor to potentially prevent that ED transfer or make sure that it's a transfer that needs to happen. So the benefits would be you could call the hospital transport faster. You can get that ambulance on site more quickly to improve patient care. You can intervene with telemedicine. And then also we wanted to enable some research to understand better trends in patient transfers using more of a model-based approach. So overall, we took data from demographics, their triage status at arrival, their problem lists, so their past diagnoses from the Epic Medical Record System, vital signs throughout the encounter, diagnosis, orders, medication, and we used data from about 160,000 patients treated at those rural sites. And then we used Google AutoML, which selected a neural network model to generate a risk score of 1 to 10, indicating the risk of transfer to a hub site. And so part of this project's value we thought was to really test out this AutoML tool to see if it does have value compared to our models that we would traditionally build in Python. And we saw that using the full visit data, the model was quite accurate. So kind of the null model of predicting every patient to not be transferred was 92% accuracy. So we got a few percent accuracy increase, and our our sensitivity and our true positive rate were pretty good. About 80% of patients who were flagged were patients that were truly transferred in reality. But one of the challenges was this was data using the entire encounter, but if you only use the data available at triage, which might be a more realistic clinical setting, the model was much less accurate. So there was a tension here between how much data you have available at the beginning of the visit and at the end of the visit, especially in an ED encounter, which is very fast paced. Some of our conclusions were it is possible to accurately predict ED transfers, but the use case of a model, especially a risk score model that is being put into a rapidly changing clinical practice, really needs to be understood better. And we were continuing to work alongside the clinical team to understand when in the patient visit would a risk score be most valuable. We also thought that we could add additional predictive variables to increase our performance. But really the research question that we posed from this question is at what point in the patient journey is input from the risk-based or the risk score based on a model most valuable? At that start of the encounter, the model is hard to trust because it has the least data available to it. At the end of the encounter, it's pretty much useless because it just reinforces what the doctor has already found. So at which point in the model or at which point in the patient journey should that optimal point be found? Should we introduce some sort of confidence score in order to really target where the point in the encounter where we have the most useful information, but we also are early enough to not just reinstate or reinforce the obvious. I'm going to hand over to Atul for a brief case study also on breast cancer.
So most of the promising idea in Mayo went through prioritization process, and if they're funded, they go to the next step, which is highlighted here. And in this step, we put a more robust team so that the algorithm which is developed at the end of this will be translated into real life clinical application. We want to make sure that they are built to the highest quality standard. So if you go to the next step, next slide. So I'm going to give an example of one of the projects we are working on. In oncology, there are many models which physicians uses to assess the risk of patients developing the risk of cancer. And one of the model which is frequently used is Tyrer-Cuzick model, which calculates patients' lifetime risk of developing a breast cancer. And it uses 86 data elements, which ranges from the patient's family history, patient's history, genetic factors, biopsy, and different radiology report. One of the challenges a physician often finds themselves is early enough in the primary care setting to use this model so that identify the high-risk patients and put them in a pathway or treatment protocol so that they are more frequently using mammogram and keeping those patients healthier. Because a lot of physicians are spending so much time with the EHR, and using this model is it's very time intensive because the data is scattered all over the EHR. And also, well, when physicians are trying to use it, they are scouring the internet or they're using the pre-appointment time to develop this model and inputting those value with the patient. So it doesn't improve patients' satisfaction with the provider. And if you go to the next slide, Adam. So one of our objectives with this project is to extract this data from the EHR, which are oftenly in structured and unstructured data, and pre-populate this model for the physician at the point of care. So it improves the patient-provider interaction. It reduces the cognitive burden of provider. and also gives the physician the ability to modify any of the data elements, so that when they're asking patients those questions, they can modify any of those elements which may not be relevant or which may have changed. And in the next slide, as I mentioned, in Mayo, we put a robust team. So it's always led by physicians who have deep expertise in this topic. And we have data engineers who are creating a cohort of the patients, but our key champions are the nurses who does the most heavy lifting in annotating the notes and the data elements with complex inclusion and exclusion criteria. And then they are hand off to data scientists who creates the model, and finally IT who actually integrates into the clinical EHR. And there are many loops, as you've seen in the figure right-hand side. There are many iterations to build a robust model. In the next slide, I'll talk about some of the challenges. And one of the biggest challenges comes in real life is with the data. Most of the data are available in unstructured data format and have very complex inclusion and exclusion criteria. So they need specialized nurses who can actually annotate those data. And even in the clinical notes, we need to identify very specific text where the data is very clearly identified as a positive data element, because there are many educational elements in the clinical note as well. And with the 86 data element, we have always find that the coverage of the data element in the EHR varies from really good coverage to very low coverage. And another key challenge is even if we develop a really good algorithm, we want to make sure that it's backed by a robust process which encourages our physicians to use those at point of care. And also we found that different technical team members, clinicians, data scientists speak different languages. So the technical collaboration between them also is sometimes could be challenging. And in the next slide, Adam, this shows our approach. We start with annotation, and then we do some inter-annotation quality check that to make sure that the different annotators are actually tagging the same data elements similarly. And they're being fed to an AutoML healthcare model to train them. And since annotation is the most expensive part of the model development, we want to make sure that we do not spend too much time in annotation. So we use what we call as active learning pipeline, which classifies the unannotated note in order of preference, so that we only annotate the notes which will be most useful in improving that model significantly. And this loop goes on for quite some times until we have a very high quality AutoML model. And we are typically aiming for upper 80s accuracy level for most of the data element. And then for the lower coverage data element, we are targeting around upper 50s of the accuracy. And then once we have a very high quality AutoML, we give that entire data set to our data scientists who will develop a custom model so that the accuracy can be actually further enhanced. And also we are working on NLP enrichment pipeline to make the annotation much more easier as well. And the next slide. I think one of our biggest question is we want to diagnose the risk or assess the risk of patients developing a breast cancer earlier enough in patients' age, more specifically when they are with the primary care rather than when they are referred to a specialty clinic such as breast clinic. But more specifically, one of the challenges in earlier stage of patient's life is we have less of those data element. And although thyroid model is more forgiving and the more data element we put into TC model, the more accurate the risk profile becomes. One of the questions which clinicians are trying to figure out is, when can we collect enough data elements so that we could use Cusick model in the point of care as a really guidance tool, so we can identify those high-risk patients and manage them more effectively. I think that was my last slide, and happy to take any questions.
Thank you, Atul, Adam. Any questions from the crowd? No. Maybe I'll start us with one quick question. I think what you're raising in the second project is the ability to create a good data set to work with. Part of the issues with much of this data set that it is being, as you said, it's basically in natural language processing. There's one thing. Another one is that it is also being based upon current decisions. And I wonder if there is a place where you can see how changes in decisions would change this data in a way that you can still apply analytics for going forward to get better decisions.
Yeah, so I think that's a great point, is what we are going to do maybe in future is to collect during the translation step, collect those feedbacks where the model may not be 100% accurate, but it will still pre-populate some of those items for the physicians. But as physicians are changing those data elements, and we are going to track changes in the data element, that can be fed back to the model to make it more accurate.
Mm-hmm. So that's really related to the ML ops model that Adam and you showed with the 10 different steps of how I make an analytics project work. So that's part of the maintenance there. Great. Thank you, guys. Any other questions? I see there's one question in the chat, if you can pick it up.
Hey, Amrika. So I think that's a great question as well with the wearables and the IoT technologies. I think especially in the ED, that's one where there probably would be some potential because especially if we can get that data from like the medical record that is like tracked by an Apple Watch or tracked by the data when they come right into the clinic, we could potentially triage them even earlier. So if they had a wearable where when they got to the ED, you put, a mobile blood pressure cuff, or you put a mobile heart rate monitor, you put other, wearables on that patient from the second that they arrive. I do think that that triage would be easier and easier because you're having that data that's not typically available until, an hour or 2 hours into the encounter, available right away. So, I think that's a great idea. But Atul, do you have any other comments?
I think one of the promising areas are the variables collecting the data for cardiovascular risk is another great application where the streaming data can be used for the patients who are high risk for cardiovascular diseases.
Yeah. And yeah, I went a couple of times with my young kids who, broke a finger, and you go into the hospital and you try to figure out why are you wasting time taking blood pressure and other vital signs, right? I mean, an 8-year-old kid broke his finger playing basketball, right? Why are you doing those vital signs? So I think a wearable would be something that would be very helpful in kind of cutting up this time. All right, thank you very much for your talk, guys. I want to take us to our next practitioners' work. We're going to have 3 people present together. Saba Vahid, who has a master and PhD in operations research and he currently leads the data and decision science team at Ontario Health, which is a small team that supports the organization with prediction and planning of initiative using a variety of analytics method. We'll have Shabnam Balmachi, who is currently a decision scientist at Ontario Health. She has a master and PhD in statistics and has lots of experience in statistical consulting in both Manitoba and Ontario. And finally, Tahira Yasmin is a data scientist at Ontario Health with a PhD in industrial engineering and expertise in operations research and its applications within Ontario's hospital sector. Thank you for joining us. Please, the stage is yours.
Thank you for the introduction, and thanks for having us here. So today I think we're gonna we wanted to just give you a sense of two of the projects that are still ongoing that have to do with wait times and how Ontario Health kind of approaches wait times management. First of all, you can see my screen, right? So,
yeah.
Okay. Okay, so I'll see if I have the same. No. So yeah, a little bit about Ontario Health. If you don't know us, we are an agency created in 2019 by the Government of Ontario, really with the mandate to connect and coordinate care in Ontario to provide Ontarians with the best possible care. We were kind of organized as a merger of 20 existing agencies in Ontario previous to 2019. And really what we do is that we coordinate the health system to help make it more efficient, to support patient-centered care. We oversee healthcare delivery across the province for many chronic conditions and beyond. We provide evidence-based standards and improvements to address gaps and take a digital-first approach to healthcare. Our team is or was part of the Legacy Cancer Care Ontario agency. There were many other agencies that previous to 2019 were delivering or overseeing delivery of care in Ontario. Those activities still continue, plus kind of new areas of focus. For example, there is a new Center of Excellence for Mental Health and Addiction. And then there is a kind of, obviously now the COVID response and recovery is something that Ontario Health also oversees. And specifically about our team, we have a very small team, multidisciplinary with expertise from operations research, statistics, health economics. And we kind of provide a range of analytics services within Ontario Health. Ontario Health is being active in different clinical or business programs. What we do, we almost act as a small consulting team within the agency, providing kind of descriptive, predictive, prescriptive analytics, as Opher kind of pointed out earlier this morning. The work that we do can range from doing vaccine efficacy studies to predicting demand for certain services to allocation of funding or capacity within Ontario. And we also support kind of methodological advisory. And really, before we kind of have Tahira and Shabnam walk us through the two use cases, I just wanted to give a bit of context around wait times management in Ontario. So in 2004, Ontario launched its wait time strategy, which really was designed to improve access to healthcare services in the province, with a focus on 5 areas, mostly surgical procedures and then diagnostic imaging. And as a result of that, wait times information system, which is a kind of a data collection system, was developed. It was housed in CCO at the time, and now Ontario Health. Public reporting of wait times became a thing to kind of increase transparency and accountability. And even for the services that wait times are not publicly reported, they're still being kind of actively monitored and managed by kind of different information systems. So really what we wanted to do today is just present kind of two projects that touch on 2 of the learnings we've had over the, since 2004 around wait times management. So one is that really you need to do kind of short range and long range planning around additional capacity, because you want your capacity for health services to grow in line with growing population and for growing demand and indication for each service. But again, being a public health system and a single payer system, you also cannot increase capacity indefinitely. So there is also another lens in terms of focusing on improving process efficiency and appropriateness of services, and then try to kind of support local solutions, as providers come up with ways of increasing efficiency and maximizing the use of existing capacity. What can Ontario Health as a provincial agency do to support that. So on that first kind of case around planning, we have a use case around kind of supporting the planning for radiation therapy capacity in the province, and how we like our team kind of provided some support in doing that, as well as kind of the second use case is around predicting wait times in emergency departments. And again, Ontario Health doesn't directly, manage hospitals or really directly operations in hospitals, but that's more of an exploration to see what is feasible to do from a systems perspective, and if we can kind of provide, services or supports to local providers around that. So with that, maybe I'll just pass it on to Tahira to walk us through the first use case.
Thank you, Saba. So I will now be talking about how we are planning for radiation therapy capacity. So as we all know, radiation treatment is an essential element of curative treatment for many types of localized cancers, and it's also very effective in alleviating the symptoms of many patients with locally advanced or metastatic disease. So in Ontario, radiation treatment investments have come a long way since the late 1990s, with the number of high energy radiation treatment machines doubling in the past 20 years, which was based on the guidance from the Cancer Care Ontario investment strategies. If you look at the top right chart, the percentage of patients seen for consultation within 2 weeks of referral has improved after approximately 40% in 2006-2007 to over 80% in 2017-2018. But however, delays still are continuing to happen despite having significant improvements in some wait time intervals over the past decade, and which can lead to additional stress and anxiety for patients and families. This can also compromise the treatment outcomes in some situations as well. Moreover, for certain population groups, such as like First Nations, they can face even longer delays while waiting for medical travel approvals. If we now look at the bottom right chart, so over the 8 past years, the number of patients receiving treatment has consistently increased in Ontario, though 2021 and 2022's data is still not completed, and both average and 90th percentile wait times have consistently increased, while it's still mostly within clinical targets, which is like 40 days for 85% of cases. So therefore, to ensure the future capital investments for radiation treatment, that these are appropriately timed and strategically placed, Ontario Health, with its provincial partners, updates its radiation treatment capital investment strategy regularly. So for current planning, the approach is based on expected patient demand and mission throughput, with considerations from mission downtime. Since the current planning methodology does not explicitly include capacity buffer, so for this particular project, our objective is to recommend a capacity buffer in addition to expected demand to be considered when we are developing this RT investment strategies and long-range capital plans. Next slide, please. Yeah. So now let me walk you through the overview of the data that we have used for this project. So all cancer treatment activities in Ontario is reported in activity level reporting, or ALR data source, which is housed at Ontario Health. However, for this request, we only had access to aggregate data on treatment volumes and wait times for all cancer centers since 2006 and 2007. The data included the number of patients who received radiation treatment in Ontario, as well as how long they waited for the time they were ready to treat to the first day of their treatment. Live wait lists are not captured within this ALR data source. So therefore, the challenge for this project was that we did not have our patient level data as well as waitlist information to complete the request. Though it could happen that we could have asked or requested the other analytics teams with data subject matter experts to provide us the patient level data, but which would require a lot of time. So therefore, for our first attempt, we are using this aggregate data to answer the question. So to solve this problem, the approach we took is like 2 steps. So at first, we estimated the arrivals and wait lists using the little loss, and then used those results to build a discrete event simulation model. So one cancer center can have multiple radiation treatment machines. Since waitlists are not allocated to machines, but to center itself, so we represented each center as a single server queue with the throughput rate set to observed historical averages, which is like that average number of patients who started treatment each day over the past year. So to estimate arrivals and wait lists using little law, we have our throughput rate and the average wait time from the historical data and can use them to estimate arrival rate and waitlist size. Then these were used on the second step for our discrete event simulation model. So in the discrete event simulation model, we set our service capacity equal to the throughput rate, which is like patients treated per day, and delay them in the service block for 1 day. Since we assume as soon as the patients start the service, they exit the queue, and we don't care about the duration of the treatment for this exercise. Next slide, please. Okay, now let me walk you through what are our preliminary results for now and what would be our next steps. So we tried a number of combinations of demand and capacity for an capacity increase for a large facility with 800 patients treated per quarter to recreate. So for our first steps results, we recreated a graph which was inspired from an article published by NHS in 2001. In that article, it was shown that the capacity buffer was inversely related to the mean demand for services. Surprisingly, we have seen the same for our preliminary results for our system as well. We have seen that as demand increases, the ratio of capacity to demand to meet the wait time target decreases. If we look at the graph, it shows that for radiation treatment, with expected demand increase of like more than 30% over the next decade, a capacity buffer of like 4 to 6% may be appropriate to use in the long range planning. And why is that? Because while capacity needs to be increased alongside the increasing demand, as system grows in capacity, it actually absorbs the fluctuations in demand better with lower impact on wait times. Therefore, lower level of excess capacity are required. So this is the results we have so far. And for our next step, as Saba mentioned, that these are both of these projects are on the preliminary stage. So for our next step, we are planning to have further validation required so that we can ensure the baseline scenario accurately captures the current state, and the model that we are having now is actually performing well for other facilities as well. Then we also want to extend simulation time and introduce a demand increase as a step function with time to see the impact of annual increase of demand on wait time growth. So now I will pass it on to Shabnam to talk about our second project.
Yeah, thanks, Tahira. Hello, everyone. Let us to have a look at our second project. At emergency departments, the time between triage and physician initial assessment is defined as ED wait time. ED wait times are reported publicly in Ontario. As an example, the bottom right graph shows monthly total number of patients and the average waited time in Ontario from January 2021 to January 2022, reported and prepared by NACRES, CIHI, and CCO. Hospitals are financially incentivized to monitor and reduce their ED wait times and lengths of stays. As an example, through a pay for performance program where 70+ hospitals participate. Therefore, some hospitals started publish live predictions of wait time provided by some external vendors. This helps for better operational flexibility, supporting clinicians to prioritize patients and adjust workflow. It also benefits improving patient satisfaction. So we decided to explore feasibility and accuracy of wait times prediction through two main objectives. First, we would like to see if we can provide the live ED wait time predictions through one central system as opposed to multiple sources that we have. And we also would like to predict changes to ED wait times as a result of a change in arrival patterns. Next slide, please. Let's now move on to overview of the data. We have two different sources that need to be combined in order to give us one central system for our required predictions. The first source, which is the live one, is ECTAS. ECTAS is an electronic triage decision support tool implemented in 2017, which includes 126 hospitals currently, ranging from 4K to 133K annual ED visits. CTAS, which is the Canadian Triage and Acuity Scale, is a guideline used by ED nurses to triage patients according to the urgency of their needs. Through the years, significant variations were identified in how clinicians interpret and apply the CTAS guidelines. And ECTAS program provides a tool that standardizes this CTAS application and ensures patients are assessed in a safe and consistent manner across Ontario. CTAS does not follow patients after triage, unfortunately. So to capture patients' information after triage, we need the second source, which is NACRIS. NACRIS is not live and has lagged data feed to Ontario Health with a monthly frequency, but includes patients' journey from arrival to departure, including time to physician initial assessment. Next slide, please. We considered a medium-sized sample facility in South West Ontario with approximately 65K annual ED visits during April 2018 to February 2022 to start. This facility was selected because of its high data reliability of ECTAS tool implementation. The top right graph presents monthly time trend of total patients along with the monthly average wait time per patient in this facility. This trend shows the disruption of pandemic and increasing in wait times. The bottom right graph indicates the distribution of wait times within each hour a day. And as it can be seen, the distribution is really wide, which can really impact the accuracy of our prediction. Next slide, please. So let's now take a look at our approach. We planned a prediction system based on a machine learning technique with the aim of providing real-time estimations of wait times for each incoming patients to the ED. The system works as you can see in the top right flow chart. The green parts are what have been done already and the rest are planned to get done in coming months. Based on previous research on waiting times and data availability, we considered a set of 8 predictors, including 5 patient-level patients as age, gender, ECTAS score, patient complaints, and waiting time between arrival and triage. We also considered 3 temporal features as day of the week, hour of the day, and day of the year to effectively capture the ED state and accurately predict the waiting time of patients. We also plan to add arrival-based features as number of arrival in the past hour. Unfortunately, we do not have required live data to make queue-based features that can help the accuracy of predictions. We also employed ensemble method, which is an ensemble of different common methods. The main idea is to combine and assign weights to several learning techniques to obtain a new predictive technique that can outperform any of those single methods. The procedure for EM training and tuning can be seen in the right bottom flow chart coming from the literature we followed for this study. The initial training set, consisting of 80% of the data set, was split into training and validation set. Each learning technique was trained and tuned on the training set following the time series cross-validation procedure. The optimal weights were determined based on the validation set. Then the distance from the actual waiting times of EM was evaluated in the test set. At the end, the accuracy of the learning technique got evaluated through different common methods, including mean square error, mean absolute error, and symmetric mean absolute percent error. Let's now look at the next slide, which shows preliminary results and next steps. Unfortunately, the performance of our EM implementation was low based on existing features. The estimate was about 69 minutes with RMSE of 19 minutes. The symmetric mean absolute percent error was really high, about 28%. The important features for prediction detected by EM were age, ECTAS score, cardiovascular and GI complaints, hour of the day, day of the year, and weekends, waiting time between arrival and triage. In next steps, we will investigate other algorithm rather than EM for performance comparison and accuracy improvement. We will also add other facilities, and arrival-based feature, as I mentioned earlier, also will be added to the model. Thanks for listening. Hand over to you, Saba.
Thank you. I mean, I guess we have hopefully 1 more minute just for wrapping up. Again, kind of really the idea was to, I guess, give a sense of how Ontario Health basically approaches wait times from multiple lenses. So while planning for more capacity, there's also kind of thoughts and initiatives to look at other ways of, again, kind of supporting either local solutions or thinking about how else we can kind of attack the problem of wait times. One thing that I think for us really stands out is that we, a lot of time, by simplifying assumptions and trying to do an iterative approach to modeling, we get a better buy-in and better kind of stakeholder trust and understanding of the approaches that we use. Again, there is a lot of interest in using data and analytics in Ontario Health to address our problems, but it's very important to be able to kind of take the stakeholders with us through the analytics kind of roadmap and be able to explain and really get their buy-in as we share the results and the approach with them. So that's kind of, as you saw with both of these, we are trying to take that kind of step-by-step approach and see how we can kind of engage our stakeholders appropriately. I'll maybe stop here.
Thank you very much. There are a couple of questions in the chat that have been raised. I think, Tahara, the first one is for you. How HHR and operation funding are taken into considerations?
Sorry. I'm trying to. Have I stopped sharing or nope? I have not. Okay. Sorry. Just trying to do that. Sorry, what was the? Yeah, I think I'm gonna maybe answer that. But what was the question again? Sorry.
How HHR and operation funding are taking into considerations in the wait times?
Right. So for that, I guess if it's specific to the radiation therapy question, the throughput of the machines, like basically in the long range planning, what's really taken into account is the expected demand based on the incidence of cancer, what proportion of patients will need radiation therapy. So there is an estimate of how much demand will be kind of for the treatment. And in terms of the machine, the planning really happens for the capital. And Jonathan, I think you're on the line. Our colleague who actually manages these long-range capital plans for radiation therapy is on the call. He can probably speak to this better. I think really the planning happens for the equipment with the assumption that the HHR will be kind of managed by cancer centers to try to run the machines.
I'll just chime in real quick. I'll just say really quickly to your question, Imtiaz. There are separate streams of work that kind of do HHR planning for the RADONCs as well as the QPP work on the funding side to deal with the operational funding. So and we are all like housed within a really relatively similar kind of group. So we do try to make sure that we are using the similar assumptions and that sort of thing that kind of feed all those kind of different models. So capital, HHR, and operating funding are all being planned in separate silos, but connected.
Hey, Jonathan, thanks for joining. Good seeing you. There's another question that I see get a little bit of discussion in the chat, and we have a couple of more minutes. So this was to Shabnam. Do you include race-based data as part of patients' features, and all of the issues of equity among different populations and different races in access to care is obviously a critical question.
Yeah, that's a good question. Thanks, Elias and Erica, to raise this. We didn't actually, so we are in a very preliminary step of the project, but we have access to SCS demographic information and race related information, that it's going to be in the next steps to add these ones and merge these ones to our data set as well and include them as the new features. Yeah, we have planned to include them, and I believe that they can actually help us with the accuracy of the predictions.
I would just add that we actually don't have race-based, but we have all the SES information, as Shabnam said. So we have like kind of based on postal code and the geography, you can kind of get a lot of information, but race specifically, we don't collect that for a lot of our data sources. There are some information on kind of indigenous populations, but again, like it's kind of hard to try to really get in race as a feature.
Yeah, we can include part of the ethnicity from SES. Yeah.
Yes, exactly.
And really, there's a lot of discussion in terms of ethical AI and how we use data like race or even gender and how it impacts different things. So that's really a critical question. Thank you very much for all of the speakers in this session. We have now a 10 minutes break. I need to stretch up myself a little bit. So I'll turn off my camera for these next few minutes, and I'll see you at 11:50. So take 9 minutes to enjoy yourself, a minute to come back to your seat, and we will continue with our third session. Thank you, everybody. Being too low. All right. So thanks everybody for joining us again. This is our last session. Our first speaker is Professor Manlu. His research is focused on the design and regulation of service systems and their applications to healthcare. He strives in his research to envision healthcare services at an affordable cost and allowing timely access and high quality. He has editorial positions in several of the top peer-reviewed journals in the field, and I'm happy that he could join us today. Nan, please, the stage is yours.
Thank you, Opher. So let me share my screen.
Looks good here.
Okay, so can everyone see my screen? Okay, great. Thank you so much, Opher, for your introduction, and also for the Roundtable organizers to organizing this exciting event. It's a great pleasure for me to present our work here on behalf of my co-authors, Yunting Shi and Guohua Wan, both from Shanghai Jiao Tong University, Antai College of Economics and Management. And Yunting is a PhD student, and I should give her most credit for her hard work in this project. I think she's here today in the audience, but now probably it's kind of midnight in Shanghai. So, I mean, most of the previous talks are focusing on hospital care. I think I'm going to taking a detour here to discuss probably a different type of hospital care. And our paper is in particular in concern with treatment planning of victims with heterogeneous time sensitivities in mass casualty incidents. So first of all, what is mass casualty incidents? It's an event which generates more patients at one time than locally available resources to deal with using regular procedures and capacity. And there could be many causes for such incidents, for example, disaster, terrorist attacks, or traffic accidents, and so on and so forth. And the characterizing feature of MCI, mass casualty incidents, is that the emergency response resources are overwhelmed by a sudden jump in demand, so making it inevitable to ration, the resources, who to save, and which kind of victims getting the resources. And some MCIs are caused by large-scale natural disasters such as earthquake, tsunami, and tropical storms can significantly damage local infrastructure, making it impossible to transport victims to functional hospitals. So here are a few examples, 2004 Indian Ocean earthquake and tsunami, 2008 Sichuan earthquake in China. Actually, we are getting some really precious data from this earthquake, which kind of motivate this particular project. I'll talk about that later. And then 2010 Haiti earthquake and 2020 agency earthquake. So when these natural disaster hits, field hospital play a vital role in disaster response. So what do I mean by field hospital? It's different from the regular hospital, but these hospitals usually is temporary medical facilities to take care of casualties on site before they can be safely transported to more permanent facilities. And these field hospitals usually are launched by nearby hospitals which remain functional, or by military efforts or humanitarian missions. The figure on the right is just an example. It is set up by the Israel Defense Force, launched from 6,000 miles, and then going to Haiti earthquake to do the rescue efforts, fully operational in just about 3 days. And it's set up in a very short amount of time and provide a wide range of care, as you can see here. So including imaging, surgeries, orthopedics, pediatrics, OBGYN, so on and so forth. And the focus of our project is actually focusing on the operating room here. And the resources is extremely limited in such situations, and emphasis of the hospital at the field hospital is to what they call do the greatest good for the greatest number. What this implies is that probably not all the patients will be able to get care or will be able to save, or just to maximize what we can do given the resources that we have. So before I jump into our project, let me first quickly talk about what's the practice guidelines in these hospitals. So since we are focusing on surgical care, so let's look at patients waiting for surgical care. So before patients are admitted for surgical care, they are triaged first. And simple triage and rapid treatment, or abbreviated as START, is a commonly used triage system in emergency medicine in the US. And I know China has similar policies in place. I believe other countries may have more or less kind of similar type of guidelines in place. So START will categorize patients into 4 categories, ranging from the most critical down to minor injuries. So labeled by expectant, immediate, delayed, and minored. So only the middle 2 type of patients are going to be considered for admission to surgical care. So immediate patients are those who require medical attention as soon as possible, while delayed victims, although they have serious injuries, but their status are not expected to deteriorate, really quickly or significantly over several hours, so they can be delayed a little bit. But the point here is that the delayed patients cannot be delayed for infinite amount of time. If you delay them for a significant amount of number, they may still suffer from deterioration. And I will talk about that in a minute. So the current guideline is always prioritize immediate patients ahead of delayed patients. In other words, if a surgical team, they are assigned with this many patients, then they always operate on the immediate patients, and then they operate on the delayed patients. And we'd like to understand whether this is the optimal thing to do. So our research question is actually very well defined. So we wanted to understand how we should schedule or prioritize treatment among those victims admitted for surgical care in order to do the greatest good for the greatest number. I will try to quantify what do we mean by do the greatest good for the greatest number in a minute. So here's the agenda for the talk. I will start by a data exploring study using the very precious earthquake data that we obtained. And then I'll move on to talk about the model and the key results, talk about quite a few model extensions and practical considerations. And then I will present a numerical study. The most interesting part is that we have done a counterfactual analysis to look at the performance of a model. And lastly, I will draw a quick conclusion. So first, the data exploratory study. First of all, some background about the earthquake. The epicenter of the earthquake is in Sichuan province in China. And the earthquake itself struck around 2:30 p.m. local time on May 12, 2008. It is the deadest earthquake that ever hit China, and it is one of the most deadest earthquake that hit all time in the world. And it has led to significant life and economic losses, and our data were actually recorded manually in a field hospital dispatched by a nearby hospital that remained functional after the earthquake. So what do we have in the data? So we have 13 surgical teams, and these surgical teams operate on 101 victims. And all these surgeries were conducted in the following day of the earthquake. And the data contains surgical sequence, surgical time type of surgeries. One thing you may notice that is the data we have are very limited. And this is because of the extremely challenging environment in data collection. All the data are collected manually. And as you can imagine, in that kind of austere environment, data collection is definitely not the priority. But nevertheless, we have this very valuable first-hand data. They represent what decision makers actually face in early stage rescue during an MCI. So it's very variable. And since we're looking at treatment planning, surgical scheduling, we're definitely interested in patient surgical time. So in MCIs, we know that victims are injured and they may be deteriorating. So we're in particular interested in whether victims' surgical time will be affected by their waiting time for care. And the data allows us to look at that kind of question. And in addition, this data also provide a test bed to run counterfactual analysis of our model. So for the sake of time, I will probably only discuss the key findings of a data analysis. So the first important finding for analysis is that we find that surgical time may or may not depending on the waiting time. So this naturally kind of divide patients into two groups, which we call unstable group and stable group. So stable victims are those whose surgical time do not depend on wait time, but the unstable victims, their surgical time depends on the wait time. Now, within the unstable group, we find that their surgical time, as expected, increase in their waiting time for surgeries. But perhaps more interestingly is that, so the unstable group, there are two categories, right? So immediate and delay. And what we find that is the delay patients actually, after waiting for some time, they deteriorate clinically and their procedure time increase at a faster rate in their waiting time. Okay, so kind of picking up. So these empirical findings really motivate our analysis, and actually this might be the initial or the first evidence, at least in the operations community, that we find this wait time dependent surgical time in the context of MCI response. So motivated by the empirical findings and also taking just a traditional scheduling framework, we developed the following model. So patients arrive at time 0, ready to be operated on. So we have two types of patients, right? Stable patients and unstable patients. And within unstable patients, they are further grouped into delay and immediate, depending on their initial clinical condition. For the sake of time, let me just focusing on the base model here, and the base model only include the delay, the unstable patients. So now the surgical time of immediate patients is assumed to be just a linear function of its wait time. And the surgical time of delay patients is assumed to be a increasing piecewise linear function of the waiting time. And one very important feature here is that delay patients will deteriorate clinically after some time, as we call this time switching time. So after this switching time, clinically, they may suffer from irrecoverable organ, suffer from things like amputation, but these could have been avoided if they received before the switching time. And also after the switching time, not only their surgical time also increased at a faster rate. Oh, sorry, am I dropped?
I think you're back on. Can you reshare your screen?
Oh, okay.
For a second, indeed.
Sorry, it's sometimes Zoom just. Okay, so I'm back. Okay, great. Sorry, it's okay. Now, to make it easier, let me use a plot to represent the patient type here. So the upper curve is the immediate patient, the lower curve is the delayed patients. Delayed patients will deteriorate after switching time S. And then after the switching time S, their waiting time, their surgical time increase at the same rate as the immediate patients. In addition to switching time, both type of patients have their due times. And what this due time represents are kind of the feasible time window to treat these patients in the field hospital. And we've been talking to the doctors and nurses that had joined those rescue events. And what they tell us is that when they arrive at the scene, when they look at the patients, they kind of have an idea by what time they should provide care to these patients. Otherwise, this patient may be just dying. So due time could also be viewed as maybe the latest time you should provide care to these patients. And the problem we have is, okay, so given a fixed number of delayed patients and immediate patients, we need to determine the surgical sequence and the start time. Our goal is to minimize the number of clinically deteriorated delayed patients subject to the due time requirements for all patients. So I guess practically, you could interpret this goal as among the schedules which minimize the loss of life, we wanted to find one that comes with the fewest amputations, right? Because amputations would definitely lead to degrade your life quality, and we wanted to prevent that, subject to we don't cause more lives in our society. Okay, so before I jump into the results, let me talk a little bit, just do a very brief literature review. Our paper draws from 3 main streams of literature: resource allocation with heterogeneous patients, traditional classical appointments, surgical scheduling, and traditional job scheduling. In terms of the modeling features, previous work has considered deterioration or weight-dependent service time. And our work perhaps is the first to consider both in making scheduling decisions. And the other thing is that our model is informed by data analysis, which provides, to the best of our knowledge, maybe the first-hand evidence on how waiting affects a victim procedure time in the context of MCI response. So now let's jump into the key results or key insights. But before I do that, let me introduce a very important ancillary result established by Brownie and Arriel in 1990. So what they do is they consider a traditional scheduling problem of a bunch of jobs whose procedure time is linearly increasing in their waiting time. And they wanted to minimize the make span. And what they find is it's optimal to process job according to this ratio. Basically, you wanted to prioritize with a small setup time and higher sensitivity to wait. And this is actually pretty intuitive if you think about it. And to make it easy to communicate, let's call this ratio the initial condition, the intercept, right, to deterioration speed ratio, I to D ratio. And build on this, what we find that is, deteriorated delay patients always have a smaller I/D ratio than immediate patients. But this does not mean that delay patients should have priority, because in our problem, patient I/D ratio change over time. Or in other words, they may also endogenize to your scheduling decision. And this is the fundamental difference between our model and the traditional model. But all these results are pretty useful in our analysis. And for the sake of time, maybe let me just focus on the key results, which is the structure of the optimal schedule in the base model. So to make it easier, here I'm using yellow to represent the delay patients, red to represent immediate patients, and orange to represent deteriorated delay patients. And the three figures here just shows the structure, the possible structure of the optimal schedule under different situations. So the first situation is when delay patients have a smaller I/D ratio, then regardless whether they deteriorate or not, we wanted to prioritize them so that we can minimize the make span. So we prioritize delay patients. But if delay patients have a larger I/D ratio, like the later two cases, then before deterioration, we should prioritize immediate patients to minimize make span. But if the due time of immediate patient is actually pretty small, meaning that your time is pretty tight, then you always prioritize immediate patients. However, if you have a little bit time, then you could try to squeeze in a little bit, delay patients in between, and you can prevent deteriorations. And what we can show is that in the latter case, the optimal schedule has this very elegant, what we call sandwich-like structure, right? So immediate, delay, and immediate. A very important observation in this analysis is that delay patients can actually have higher priority than immediate patients in optimal schedule. And this is a stark contrast to START and conventional wisdom, which always prioritize immediate patients. Okay, so we have also considered several model extensions, pretty substantive extensions. So the first one, one may argue that the driver to prioritize delay patients is because they clinically deteriorate. And we're looking at different setting objective where we suppose that the delay patients do not deteriorate clinically, but their surgical time still increase, but clinically they don't deteriorate. And if we only wanted to minimize the make span, we still see that sometimes we wanted to prioritize delay patients. The second extension is we consider a general post-switching time weight sensitivity, and the same structural results remain hold. And lastly, we look at a general model with both stable and unstable patients. The same thing still hold. So the key finding here is that, regardless, what kind of generality we try to generalize the model, delay patients may still have higher priority than immediate ones in the optimal schedule. And these extensions just means that this important insight is pretty robust. We also have considered several practical implementation issues. The first one is, what if you have a second batch of patients rescue from the incident, and how should you do? And we could just re-optimize the schedule using the procedures we identified. And the second consideration is the care coordination among multiple teams. And the motivation is that in our data, we observed that the number of surgeries per team ranges from 6 to 11. And a natural question is, if we can balance the workload at the beginning, maybe we can do better. And to do that, we develop a dynamic program to allocate victims upon their arrival so that we can balance the workload. So in the last few minutes, let me just quickly summarize our numerical study. So the first thing we do is we do a robustness test. So one assumption we made is that the procedure time is deterministic when the waiting time is given. This allows us to derive the optimal schedule and compute it really fast. But what we show is that even when the procedure time is random, our schedule is mostly on time, and if not, has fairly limited tardiness. But perhaps the most interesting study numerically is the counterfactual analysis. So let me spend maybe 1 or 2 minutes on that. So we're using this 13 surgical teams, 101 victims as the test bed. And then remember that we have both stable and unstable victims. So in the counterfactual analysis, we're actually using the general model to do it. And what we do is we evaluate both the then implemented schedules, which is the START policy, which always treat immediate patients first, compared to those generated by our model. And we look at 3 possible scenarios. One is that we just optimize individual team schedule, assuming the same set of patients is assigned to the team. And second, the third is that we reallocate patients among all teams. And the middle one is that we first organize surgical teams into a few pods and then just do workload relocation within each pod. So here, the table here is the team schedule optimization alone. So we fix the patients to be served for each team, and then we just do schedule optimization there. And what we find here is it leads to 32% reduction in the number of deteriorated from 25 down to 17. And the make span is also reduced by 8%. And this 8% reduction in surgical make span means more time to save more lives. And here we look at
and just 1 minute to go if you can, all right?
Yeah, I'm almost done. Yeah, sorry. So on the left panel is the partial coordination, where we show by do a partial coordination, we can reduce deterioration down another 44%. But if we do complete coordination, then we can actually reduce from original schedule 56% reduction. And the partial coordination idea is actually related to Vahid's presentation, where a sparsely connected network might actually help a lot. So finally, let me just do a 30-second conclusion. We develop scheduling models to inform treatment planning in field hospitals, and we identify conditions under which delayed patients have higher or lower priority than immediate ones. And we demonstrate that the data-driven approaches can significantly improve patient outcomes and operational efficiencies in MCI response. And we suggest that the policymakers should pay attention to data and scientific modeling approaches rather than using intuition and simple heuristics in emergency response. And to facilitate the application of models, we have also developed this prototype of web-based tools to implement our base model, accessible from this website. So sorry for running out of time a little bit, but this is all I have today. And thank you very much for your attention. I'll be happy to take your questions.
Thank you, Nan. Daniel wrote a question in the chat, and I hope you can respond to him on the chat as well, because I do want to continue with our next speaker. Thanks for the great presentation.
Thank you.
Very interesting, and this is really kind of explaining why we have this session that suggests that managing waiting time is not simple, right? Especially in healthcare when things can deteriorate.
Exactly.
Our next speaker is Yuan Jin. He's a 4th-year PhD candidate at Southern School of Business at University of British Columbia. He's supervised by Professor Yichuan Ding, Mahesh Nagarajan, and Steven Schechter. He is broadly interested in data-driven and analytics with applications to healthcare and other public sector problems. His research has been published on plastic. He published research on plastic surgery, plastic and reconstructive surgery, and he presented in a couple of wonderful conferences, including Informs Healthcare meeting. He's been awarded the Memorial Graduate Scholarship at Southern School, and he is a co-op project on innovative data. Yuan, please, the stage is yours. Thank you for joining us.
Thank you for the introduction there, Opher. Okay, so can everyone hear me? I'm just testing. Okay, great. So hi everyone. Good morning and good afternoon. I'm very glad to attend this Roundtable online seminar series and to hear these many great talks regarding operations, research, and healthcare. So thanks Opher and organizers for organizing this great event. Today I'm going to talk about surgical teams and their behavior in operating rooms. So the title is does delay stimulate speed up? Evidence from operating rooms. So this is a joint work with Professor Yichuan Ding and Professor Steven Schetcher from UBC and McGill. Now let's get started. So let's first talk about our motivation and about schedules and disruption of schedules. So schedules are everywhere, especially in healthcare service. However, sometimes it's common to observe and maybe to experience disruptions of the schedule. For example, this is some statistics by how the healthcare appointment schedules are disrupted by COVID-19 pandemic. So it leads to great cancellation and delays among patient appointments. So basically, we can see the rate of cancellation or delay increases by about 30% recently. Another example is, so I think this is a bad photo for those travelers using flights. So in fact, in the airline industry, approximately 20% of flights are delayed. So that's two most commonly seen examples of disruptions of schedules. In fact, in operating rooms, the deviation from a prescribed schedule can be also huge. According to a paper by Qi et al. 2017, more than 70% of surgeries start late compared to the schedule in their hospital. Okay, so that's our motivation. And however, the responses of service providers towards delays and disruptions can be twofold. And also, the associated consequences can be complicated. Therefore, in this research, we consider two main questions. First is that how surgical teams respond to real-time deviations from the planned schedule. Second, what are the potential associated influences on post-surgical complication rates? That's basically quality impact. Okay, so our research connects to 4 streams of literature. First, the surgical productivity and scheduling. This is a very large area, and many papers are in this area. The second one is efficiency quality trade-off in service queues. So both healthcare practitioners and operation researchers are very familiar with these topics. And third is project and airline management. So we connect to them because they share a similar schedule disruption response background with our story. And finally, we connect to econometric literature of dynamic panel models and Arriel bound GMM estimator. Okay, so let me introduce and briefly talk about our clinical setting and data in this study. So our study is conducted based on surgery data, including both planned and real-time timestamps of surgeries in a large hospital in North America. The time period is from April 2018 to October 2019, so that's basically 1.5 years period. In this hospital, we have about 119 surgeons and about 9,700 surgeries on average annually. And we have patients with various conditions and procedures, totaling 10 departments in the hospital. The surgeries include both elective and urgent add-on surgeries. Basically, elective surgeries are those are prescribed with a detailed schedule, and urgent add-on cases, they are inserted into the shift without pre-schedule.
Ewan, just a quick question. So the oldest person is 24 in the patients group, or is this just a...
Yeah, because it's pediatric.
Oh, sorry. Thank you.
Yeah. So yeah, it's the... Okay. So regarding the operating room schedules and protocols, we have 9 regular ORs, and normally a shift starts from 7:45 a.m. or sometimes 8:20 till 3:30 p.m. or 5 p.m. in the afternoon. So the OR shifts will be scheduled in advance, and typically a sole surgical team will occupy a OR for the entire shift on that day. And when they schedule the case, they try to maximize the utilization rate of each operating room because they are precious healthcare resources. So we conducted some data cleaning steps for the original data set. We first remove all the diagnostic cases because they are not surgeries. We also remove those shifts with less than 3 cases because they include the less dynamics we need for the research. And we also identify those add-on cases because they don't have a schedule and they are abruptly inserted into the shift without the pre-known. So they don't exist in the original schedule. And we remove those add-on cases, and we also remove those overlapped cases. And all cases after the add-on because they disrupted the original schedule. So our final sample includes about 8,612 cases from 2,029 shifts. On average, there are about 4.2 cases per shift, and it ranges from 3 to 9 surgeries. Okay, here I present a snapshot of the OR slate, that is the OR shift schedule. So this is a snapshot from the system. As you can see, the shift starts at 7:45 a.m. in the morning for the first case, and the final case finishes at 3 p.m. In the afternoon. So it consists of 3 cases, and you can also see they have the scheduled start time, end time, and PIR means the patient in room. That's basically the procedure duration of the surgery. And you can also notice that there exists a 30 minutes block between 2 consecutive surgeries. So that's the turnover duration left for the cleaning team to clean and prepare the operating room for following surgeries. So this is a diagram showing a sequence of activities occurring in the OR. Basically, we can see that the main part is the procedure duration, that is the duration from the patient entering OR to exit OR. And in the procedure, we have non-skin to skin time. That's basically preparation, setting up device, anesthesia. And we also have skin to skin. That's basically the incision to closure duration. And we also have the turnover duration, that is between 2 consecutive surgeries, as I just mentioned in the schedule. Okay, so after we get familiar with these settings, we propose some definitions and terminologies we use in this research. So the procedure duration, as I introduced, is defined as the difference between exit room time and enter room time for each patient. And we have the relative procedure duration, RPD for short. It measures the extent of speed up, slowdown, and it is defined as the actual procedure duration minus scheduled duration. And similarly, we have the relative turnover duration. That's the difference between real and the scheduled turnover time. And we have the observed deviation from the scheduled start, DSS for short. So that's how a case deviates from the schedule at the start time. So it is defined as the difference between actual start time and planned start time. So if it's positive, then it means that, okay, the case is delayed by maybe, for example, 10 minutes, if we observe a positive 10 for this term. And we empirically investigate how the deviation from scheduled start impact the following surgery's relative procedure duration, that is speed up or slow down for the following surgery, controlling other variables. So this is another diagram showing the difference between schedule and reality. We see that the green boxes represent the scheduled procedure duration, while the yellow boxes represent the realized surgical duration. This shift consists of 5 cases, and we see that obviously the second case is delayed, so it has a positive DSS. And also we can see that there are some discrepancies between the scheduled duration and realized duration. And basically the DSS, the deviation from schedule equals the cumulative summation of all prior cases, relative procedure duration, and relative turnover duration by this. And you can see this relation clearly. Okay, so here we provide some statistics of the key variables. So we see that on average, from the first row, we see that the real procedure duration for each case is on average about 77 minutes on average. And also we see that RPD, the relative procedure duration, is about -0.8 minutes. So on average, a case is speeded up by about -0.8 minutes. And also the deviation from schedule is 8.7 minutes. So on average, we observe a case is delayed, that it starts late compared to the schedule by about 8.7 minutes. So getting behind of the schedule is a common, is a likely scenario, although sometimes they also get ahead of the schedule. Also, we have some dummy variables of the post-surgical risks. We have 7 30-day readmission and reoperation rates. That's also observed in data, and other patient demographics are also recorded in the data. Okay, so now we present our model and estimation process. So we consider a quite direct and plain linear model. And the left-hand side, we have the response variable as the relative procedure duration for a case. And on the right-hand side, the key variable of interest is LIT, which is the DSS, the deviation from schedule. And we also notice that we have an important relation, that is the DSS, the deviation from schedule, equals all prior cases RPD and eta IT, which is the relative turnover duration. So due to the existence of such a autoregressive structure, so we cannot just apply simple OLS estimator, because actually in the econometric literature, there's a term recording such a bias that will be generated when we apply OLS estimator. It's called Nico bias. And therefore, we adopt the Arriel-Bond two-step GMM estimator. I skip some technical details here, and they're in the paper. And basically, we utilize high-order lagged regressors as additional instruments to obtain some moment conditions and to obtain consistent estimates. Okay, let's talk about our estimation results. So gamma is our parameter of interest, and gamma represents our first research question. So we find that we also report the results of OLS, and we find that actually OLS has a negative downward bias compared with the GMM estimator. So it shows that, so we have estimates ranging from -0.15 to -0.2. And we also control for other fixed effects and patient attributes to obtain a general understanding of what does this mean. So first we have negatively significant estimates. Let's consider a scenario of 10 minutes delay at the start of a case. Then the surgical team would expedite by 1.5 to 2 minutes faster than scheduled duration. This is average term and control other factors. Vice versa, we also notice that if they get ahead of the schedule by 10 minutes at the start of some case, they will slow down in the following surgery. And the procedure duration can be prolonged by an average of 1.5 to 2 minutes compared with the schedule. So it reflects, we call it a negative feedback mechanism in the operating room shift dynamics. Basically, by this term, we mean that surgical teams always manage to minimize their deviations from the schedule. So we observed this kind of a delay speed up mechanism. Okay, so these are two simple diagrams showing the difference between positive feedback and negative feedback. Basically, if it's positive feedback, then we see that it's kind of amplifying all the input perturbations to the system. If it's negative feedback, then we're always trying to minimize the impact of deviations from the schedule or the input perturbation. Okay, another interesting thing is that we consider the surgeon seniority as a moderator. That is, we want to see, okay, so we know that surgical teams may speed up when they face delays in the schedules. And how will the leading surgeon's seniority, as measured by their experience levels, impact this phenomenon? So we have 4 different groups categorized by their years of experience, from less than 5 years, 5 to 10 years, 10 to 15 years, and greater than 15 years. So we observe that the estimates are only negatively significant for the last group, which is the senior surgeon group. So it shows that basically the surgical teams led by a senior surgeon, they tend to be more evident. When there is delay, they will speed up. Okay, now let's talk about some quality topic. So here we consider the relative procedure duration and its relation on the post-surgical 7 30-day readmissions and reoperations. And a natural thinking is to apply the Probit model. So we explore the relation between RPD and readmissions and reoperations. They are proxies measures for surgical quality. And however, there's an issue here, because to identify the correlation between RPD and readmissions is not difficult. We can just apply Probit model. However, to infer a causal relationship is hard. And why is that? Because, for example, there could exist some confounders in the unobservables. For example, complications during surgery, unknown special conditions of the patient. For example, a confounder may lead to increased RPD, that is prolonged surgical duration, while simultaneously it also leads to increased readmission likelihood. Therefore, in the data, we can observe positive RPD and increased readmission likelihood. However, the causal link here is wrong because they are controlled by some confounders. Therefore, we utilize the deviation from schedule start as a valid instrument variable to address these endogeneity issues. So here we present both the IV Probit models and the Probit models. So you can see that in the normal Probit models, we have some positive and significant estimates for 30-day readmission rates and 30-day reoperation rates, while they are not significant for 7-day. However, after applying, these estimates are actually upward biased. Actually, our correlation of errors show that there exists a positive correlation between the confounders and the RPD. So in our IV Probit models in panel A, we notice that all the estimates are negatively significant after we utilize our IV to address the upward bias.
Ewan, just 1 minute if you can wrap up, please.
Sure. Okay, so we find that our IV can address upward bias, And in fact, a longer RPD slowdown leads to lower readmission and reoperation rates, and vice versa. Shorter RPD speed up leads to increase the 7 and 30-day readmission and reoperation rates. So utilizing this novel instrument variable, we correct the upward bias. We also conduct some counterfactual analysis, and for time reason, I skipped some details. Basically, we try to see how this negative feedback delay speed up mechanism can has some impact in the overall on the overall operating room shifts. So we find that basically due to if we remove this negative feedback mechanism in the counterfactuals, the deviation end of shift time will increase by about 30%, while the 30-day operations will decrease by about 8.4%. So that's from 2.75% to 2.5%. So we can see this trade-off between efficiency and quality. So here we present some managerial implications regarding our research. So we identify the delay speed up mechanism in all our functioning, and surgical teams with senior surgeons tend to be more responsive when they face deviations from the schedule. We also identify that speeding up in the procedure increase both 7 and 30-day post-surgical readmission and reoperation rates. And overall, such negative feedback reduces the deviation from schedule while increases 30-day reoperation rates from our counterfactual analysis. So here are some contributions regarding both the methodology and the practices to healthcare research. Basically, we adopt a novel IVE to address the endogeneity issue when we study speed quality trade-off. Okay, so that's all. Thank you for your attention.
Thank you very much, Yuan. Given time constraints, if anybody has any questions, please use the chat to do this. In the meantime, I will introduce our next esteemed speaker. This is Professor Hussein Abouhi Mearizi. He is an associate professor of management science and the Canada Research Chair in Healthcare Analytics at the University of Waterloo. Over the years, he has worked with a number of health organizations, including Memorial Sloan Kettering Cancer Center, Ontario Health, Manitoba Health, and several hospitals to help them leverage their operational and strategic data for improved performance. And Hussein, the stage is yours. Thank you for joining us today.
Thanks, Opher. Thanks for your invitation. Thanks for organizing the event. My work focuses on efficient patient scheduling, and this is a joint work with my students and a colleague of mine, Ishraqi Qadimi Khaja Arzani. The motivation of the work is really the backlog created due to the COVID-19. As you may have heard that because of the COVID-19, we have huge backlog in Ontario. Based on the report by Ontario Medical Association, and then there is more than 15 million backlogs for surgeries, diagnostic exam, screening, and other medical procedures. And based on some reports, it's really going to take several years to bring back the backlogs to the pre-COVID-19. There is an estimation for 3.5 years to 5 years and so on. And in particular for MRI and CT scan, this really wait time is really high. Even before the pandemic, as recently President of the Canadian Association of Radiologists mentioned, the wait time was more than 80 days, while the goal in Ontario is to serve patients within 1 month. And as you see here, among all backlogs, MRI services and the CT scans have the highest number of backlogs currently due to the COVID-19. For MRI and CT scan, is really the goal is to reduce them down because of the huge negative impact on economy. Based on a report written in 2019, really the cost of delay in serving CT scan and MRI services in Canada was around $3.5 million. And then back then, it was estimated that if they want really to reduce the backlog and to reduce the wait time, they really need to spend around $500 million to modernize the machines and have new machines. Our goal in this work is to come up with an efficient patient scheduling so that we can reduce the wait time and hopefully we can serve patients faster. This is in collaboration with Cancer Care Ontario, and the data set that we have is the wait time information system. Saba discussed about this database in the previous session. It was created back in 2014 to monitor the MRI and CT data in Ontario. We have access to this data for around 3 years for around 70 hospitals. This data set really, as Saba mentioned, captures really different covariates, different time stamps, including the arrival time of a request, the service time, the length of the service, priority, and so on. It's a very rich data set. In general, if I want to talk about these Ontario MRI services, we can think about a multi-priority, multi-type patient scheduling, because we have different types. We have around 10 different MRI services conducted in many hospitals, including head, spine, abdomen, and so on. And at the same time, we have different priority levels for patients. We have priority 1 to 4. And the goal is to really serve patients of priority 1 faster than priority 2, faster than priority 3, and so on. Actually, the goal is that to serve priority 1 in 1 day, priority 2 to 2 days, 3 in 10 days, and 4 in 28 days. Therefore, here really we are facing a multi-type, multi-priority patient scheduling. I don't want to go to the detail of the literature in scheduling. Patient scheduling has been studied in the literature for a long time, and it has been considered from different aspects. It has been considered from what is called inter-day scheduling, the meaning that at the time between the patient arrives to the system and the day of the service. It has been also considered from intra-day scheduling, which is mainly focused on appointment scheduling and indirect wait time. Our work is more related to the advanced scheduling or inter-day scheduling. We really want to focus to manage the wait time between the day that a patient request is received and the appointment day. Let me briefly discuss the patient scheduling in general, and especially advanced patient scheduling, and then I'm going to discuss the challenges that we face and then how we can adopt data-driven approach to tackle those challenges. To discuss the patient scheduler, you can think about the calendar, scheduling calendar, and then you can think about one specific day, March 7th. There is a person called a scheduler who needs to schedule all requests received by the hospital or by the service provider. Then the scheduler should look at all available appointment times in the future, and then based on some estimate about the future arrivals, allocate one time slot to this patient. And then when time slots are allocated, then those will be appear from the calendar, move to the next day, and then the same procedure should be performed, and so on. From the scheduling perspective, the challenge is the overlap between time slots that can be allocated on day 7 versus day 8. If you think about day 7, March 7 as the first day, then here, and there is a booking horizon here that the time slot can be allocated to patient, and day 2 as a March 8, you will see that there is a significant overlap between actions that can be taken in different periods on different days, and so on. That makes the problem of patient scheduling in general very challenging. And then we need to take into account that we have different types and different priorities requiring different service times and so on. The focus of our work is really to consider multi-period setting. It could be finite horizon, infinite horizon. Now consider the finite horizon, meaning that we have a limit in the future days to future calendar that we can allocate to patients. And of course, there is a limited capacity per day. And the goal is that to schedule patients as they arrive to the system. To do that, when we work with the data, we observe two main challenges. One challenge is really high variability in the arrival. When you look at, for example, this is the data from one hospital, is a large hospital in Toronto. We observe that there is a really high variability in the daily arrivals that we observe. And then we need to take into account that this is really the total arrivals, and if you can consider the type and then priority is going to be really highly noisy data that we have. The second challenge that we have when we want to schedule patients is really what is called curse of dimensionality, is the different actions that the scheduler can take, different time slots that the scheduler should think about and allocate one to the patient. Again, here, if you think about March 7, then the scheduler can allocate a time slot on the same day, the day after, and based on the available time slot, allocate one of them, considering that there will be a daily arrivals in the future, and all of them should be somehow allocated, and then they need to accommodate somehow the urgent patient. Therefore, considering all possible actions, all possible options, and allocate to one time slot to the patient makes the problem very challenging. And then our goal is really to provide a data-driven model, fast, efficient model that we can tackle these two main challenges. To do that, to do the first one, to tackle the variability, we developed a data-driven robust algorithm, and I'm going to discuss it briefly in the next slide. And then to tackle the curse of dimensionality, we are going to adopt an adaptive scheduling approach. Let me discuss what we mean by each of them. Again, consider one day in the period 1 here, or you can think about the March 7 here. Then to tackle the variability, what we can do at the very first day here, we can consider somehow the samples of the data, the past historical data that we have. We can take up the samples so that those samples somehow represent the future and work with those samples. We can all, at the same time, think about, somehow we predict those demands in the future, and then work based on the predictions that we have. We did both, but the focus of this, my talk today is just take the sample from the data that we have. Therefore, what we do here is that what we have in mind here is that if you're on March 7 and you want to schedule, to consider the future arrivals, we are going to take samples based on the data that we have, and then we take those samples to the algorithm that we develop, and based on that, we to schedule patients. To tackle the second issue, which is a case of dimensionality, we are going to solve the problem adaptively. And then by adaptive means that instead of consider at any given time or at any given day, like day T here or March 7 there, really instead of considering the rolling horizon in the future, we are going to ignore the rolling horizon. We assume that at any given time, we are going to solve the problem only once. And then based on that, we are going to schedule patients. But of course, we are going to do the same thing in every single period, meaning that we are not going to do it at the beginning of the horizon. We'll do it at the beginning of the horizon, the first day, second day, and so on. March 7, 8, and so on. Therefore, at any given time that we solve the problem, we ignore the rolling horizon effect in the future, and then we schedule based on the samples of the data that we have. And then when we solve the problem, then we want to go to the next period, we ignore the actions, the optimal action of the future period. We just schedule based on the action of the current period and ignore the next one. Just I want to emphasize that we need to take into account the future arrivals somehow to make sure that we keep capacity for those arrivals. And somehow the actions that you see here as the X hat, as the solution for the future periods, those capture somehow to allocate capacity for the future arrivals. Therefore, we solve the problem every day and then ignoring the rolling horizon, but considering somehow the future arrivals in the model. To do that, as I mentioned, we use a data-driven approach. The data-driven, I'm not going to detail of the model, but the goal is that to minimize somehow the weighting cost and the capacity cost. The weighting cost somehow captures the effect of the type and priority, especially the priority, since some of them should be served faster. And then by considering a higher weight for those patients, we penalize the objectives so that they will be scheduled earlier in the calendar. And also we have a capacity cost because some hospitals may decide to go extra hours. In Ontario, we have hospitals that they are working 8 hours for MRI services, 12 hours, 16 hours, and 24 hours based on the data that we have. Therefore, somehow to capture the extra hours that they may work, we have this capacity cost. And then the model is purely data-driven in the sense that to solve the problem, we try to consider the worst-case perturbation in the data that we observe. Therefore, to solve the high variability, we take samples from the data and then try to make sure that we can control the high variability in the future by considering the maximum worst case that we have. We developed an algorithm to solve this problem. I would be happy to discuss the algorithm later on, but to keep my presentation in time, I'm not going to the detail of the algorithm, but basically we have some parameters for the algorithm. The parameters are the service time required. It could be the function of the priority, it could be the function of the type, and we need the cost coefficient to consider the priority and type again. And then what we do in every single period, we observe what has happened so far. And then we can, based on that, we can obtain the remaining capacity in the future, which means that the available time is stored in the future, for example, for the rest of the month. And then based on that, we put them to the algorithm, and we also take samples from the data, independent samples from the data. We took those samples from the historical data so that they represent the future. Those samples could be time dependent and so on to make sure that if there is any time effect in the data. And then we run the algorithm. This algorithm, I want to emphasize, very fast. The complexity is really low, and we can solve it in the order of seconds. Let me now show you some numerical examples based on the data that we have. Here, what I'm showing you, the comparison between the data-driven robust framework that we have, the algorithm, versus the stochastic model. And by stochastic model means that we are going to consider them, we are going to minimize the expected future cost, but we are not taking this perturbation into account. It's basically minimizing the expected weighting cost. This figure shows this relative gap between the data-driven robust approach and the stochastic model. And then the x-axis is the booking horizon, then the y-axis is the relative gap. As you see here, if we really want to schedule for 1 day or 2 days, then the simple stochastic model can be efficient. But when we are going to schedule far in the future, like in the next week or next several weeks, then really the perturbation data may bother the system, the efficiency of the model significantly. And especially for MRI services that now we are going to schedule for the next month or 2 months, really the stochastic model may not be efficient, but the proposed approach is very efficient. And then here we have data for 4 hospitals. These 4 hospitals were picked randomly among 70 hospitals that we have 66 hospitals data that we have. And it shows that even if you are going to schedule for 40 days, really the gap, even for the red hospital here, hospital 1, it could be up to 90% compared to the stochastic model. Therefore, it seems that the data-driven model compared to the stochastic model works very well. Now, of course, the question could be that what is the accuracy of the model? Because now we adapt the data-driven to handle the variability, and then we consider the adaptive approach to tackle the case of dimensionality. Then the question would be, what is the efficiency or the performance of the adaptive approach? To handle that, we consider regret. And the idea behind regret is simply that to find a gap between the expected cost of the data-driven model proposed and really somehow the offline model, meaning that we assume that we knew the data and we want to compare the data. Therefore, we are going to capture this gap to see really, to somehow examine the performance of the adaptive approach. What we observe is that we have some technical contribution regarding that, how we can capture this regret function. I'm not going to in detail of that, but we can show that we can decompose this function based on the period, and it is concave in general. But it's really practically what is really important is this number here. We define what is called relative regret, and what we do is that we consider the ratio of the regret and this offline model that we have, the expected offline model that we have. And what we observe in the all data that we have considered so far, the gap is really between 10 and 35%, and mainly below 20%. Of course, here the time horizon that we consider is from 1 day to 30 days for the book, sorry, not time horizon, the booking horizon. Therefore, for the booking horizon of a month, the gap that we see is 10 to 30%. Considering that the offline model really is the best possible action that we can have, which means that really having the full information, the adaptive approach really is working very well. Now, I want to provide one more insight based on the data that we have, and especially about the backlog that we have. And this is related to the previous talk as well. One of the key observations that we have in the behavior operations is that there are some covariates that affect the service length, the service time. And it has been observed in the literature of behavior operation for a long time, even in manufacturing, in healthcare, service, different service systems. If you put back-to-back similar jobs, the efficiency of the agent can increase, and therefore the throughput can at the same time increase. Since we have a backlog, huge backlog of patients, we also did examine the impact of different covariates on the service time and the throughput. The very first thing that we can think of as sequencing, as I mentioned, we observed that the sequencing of similar really jobs or similar types of services can really reduce the service time and therefore increase the throughput. Even we went to look at each service type separately to make sure that really we can capture it accurately in the model. And at least we see for many services, we have this, we can see this effect of sequencing. And we did conduct a very accurate econometric model and then hypothesis testing to make sure that we accurately capture the impact of sequencing and other covariates. I'm not going to the detail of that, but I just want to show you, to keep it in time, one result to highlight the impact of the sequencing. This is the data. We know that as of 2020, the backlogs increased, and then for MRI services around 500,000 cases now. Now, what we did in this model, in this simulation, we considered the cases that we have at this time and say that, okay, what would happen if the hospitals go back to the regular capacity and they want to serve patients as they did before the pandemic, which is this really the red curve here. And then what would happen if we just add to this model, to this red one, the sequencing. As you see here, when we adopt the sequencing in the model, the performance can be improved and the throughput can increase. Of course, to be fair, in this simulation, we consider the best outcomes of the sequencing, which means that we consider we can sequence up to seven jobs, 7 services. But even if we reduce that number to 3, 4, still this green curve is going to be the below the red curve. And then, as you see here, we can really reduce the backlog faster by considering this covariance. I want to emphasize that since we have a backlog and we know the patients that they need to be there, we can learn from the data a lot, and we can consider different covariates, patient covariates that can help us to have a better schedule, and we can reduce the wait time of those patients waiting.
Yeah, Hussein, I hope you wrap up. Can you go one picture back for a second? So, I mean, with the graphs with the green and red ones. So yeah, even if they use kind of the optimal sequencing, you suggest that the current backlog is going to go to the levels of pre-COVID in 2 years. So without adding capacities, basically we're in big troubles in this sense.
Yes. The current estimate is there are different estimates, but I've heard of 3.5 years, heard of 5 years, I've heard even more than that. For Manitoba, actually, I heard 5 years, 7 years, and so on. Therefore, it's not going to go down, immediately. It's going to takes time to go back to the pre-pandemic.
All right. So 1 more minute to wrap up because we're out of time, please.
I'm done, and then I can just say that the focus was to come up with a data-driven fast algorithm, and we can take different approaches. This work was based on take samples from the historical data. We have another work that we work with the prediction of the demand. And also I want to mention that there is an ongoing work with Opher, which is really taking into account the weight target. This is based on the reinforcement learning and joint with Opher, Oded, and 2 former postdocs, Atta and Yang. Thank you.
Thank you very much, Hussein. Thanks everybody for joining us today. Thanks again for all the speakers. I enjoyed the day a lot, and I also learned numerous things. So I'm very happy that everybody could join. Really, the speakers have done an excellent job in my mind, and I felt that the theme of how we push forward the healthcare analytics has been well exposed here, from the difficulties in responding quickly in COVID situations where data was not available at the beginning, say for getting vaccines and so on, to managing analytics in practice and the difficulties of interacting with the people in the field, the nurses, the doctors, and so on. And finally, with the context of managing waiting time, even when data on this is available, the complexities of healthcare, where some delays cause a little bit more impact on what would happen in the future, and the impact of the corrective action on what will happen in the future, demonstrate there's still much work to be done here. I was also very happy to see how the 4 types of analytics that I mentioned at the beginning, descriptive, predictive, comparative, and prescriptive, obviously, are being exposed in those different works. And I'm happy to see that when we use technology better and better with the time, hopefully we can get better access to care and improve healthcare outcomes in terms of quality and satisfaction of patients and staff, and also without paying too much in terms of cost. So thank you very much, everybody, for joining today, and I'm looking forward to see you face to face soon. And worst comes to worst, next year in the roundtable. Bye-bye, everybody.
Thanks, Opher. Just a quick note to everybody that we will be circulating the decks and the recordings so we can keep the conversation going. If anyone has questions that weren't answered or want to get in touch with any of the presenters, please do reach out to me or to Opher. My email will be in our follow-up that we'll send to all of you. So my thanks as well to everyone. Fantastic event, and wish everybody a fantastic afternoon. Take care.
Bye-bye, everybody.